a year. And this is why it is so important that we are able to set up a system of care for STEMI in India. STEMI India was set up by myself and Dr. Ajit Mulasari with the primary aim of bringing the latest information in STEMI care to India and to help governments both in India and across the world to develop systems of care based on our experience. So in this talk, I will take you through the STEMT and STEMI program, the models that we have developed, the reasons why this would be the ideal program for low and middle income countries, look at some of the digital tools that we have developed, look at how we implement the model, and finally talk about the future plans. So the T and STEMI program, I think, is something that all of you are aware of, where we combined the two strategies of pharmaco-invasive with primary PCI in a hub and spoke model. The hub hospitals, if a patient presented directly, would have primary PCI there, but if a patient presented to a peripheral hospital, then he would have thrombolysis in the peripheral hospital and then be moved across to the hub hospital for pharmaco-invasive treatment. The landmark trial that we did, which validated this model, was published in JAMA Cardiology, and this is the paper. We had 4 clusters where we had hub and spoke models, and we showed a significant reduction in 1-year mortality, an absolute reduction of 3.4%, and this was highly significant. We were also able to show that for every rupee that we spent, there was 3.58 rupees gained by the economy. So both mortality benefit and cost benefit was established. Now, there were 4 key aspects to running this program. You're all aware of that. There was both a hardware and a software component. There was the ambulance network, primarily the GBK EMR, the 108 ambulance services, which were partners to this project. And I think most important that I would consider is the fact that in order to have equity of care, we linked it with the statewide health insurance scheme, which ensured that the BPL or the below poverty level patients would have access to the best treatment that is available. So what are the models that we developed? Now, when we look at the models, it depends on the geography, it depends on the infrastructure availability. But one of the things that we quickly learned was the ECG had to be, or a solution for reading ECGs had to be an integral part of this program, because many of the smaller hospitals, say community health centers or small hospitals, which were spoke hospitals, did not have the confidence to diagnose STEMI and start thrombolysis. And therefore, there are different ways in which we've looked at this. If it is part of a STEMI cluster, then the local ECG diagnosis is made by the hub hospital doctor. We have a tele-ECG model where ECG is sent to a dedicated ECG service, where a remote diagnosis is made with a turnaround time that we believe will be less than 5 minutes. We are now working on a tele-CCU model in hospitals which are very, very peripheral. We would have real-time hand-holding of managing these STEMI patients. And this is a model that we are in the process of piloting. So let's look at model 1. And this is a hospital, say, or a group of hospitals that are in the periphery where thrombolysis is the only thing that we're looking at. So what we have essentially are spoke hospitals with a tele-ECG facility available. Patients will be shifted to a tertiary care hospital only if they have cardiogenic shock, or there is clinical or ECG evidence of failed thrombolysis, if they have hemodynamic or electrical instability following thrombolysis. So it's not a routine pharmaco-invasive treatment that we envisage here. It's only thrombolysis. So it's really in peripheral or in states where you cannot really link them with the hub hospital. So here we have a tele-ECG. So you have a patient, a tele-ECG facility, and then you do thrombolysis. The second model that we talk about is a similar model But again, here we have a tele-CCU facility which is available. And this is in a process that is in development. So what we envisage is a real-time hand-holding of the peripheral doctor as he does his thrombolysis and manages the patient during the acute phase. So you have both a tele-ECG as well as a tele-CCU facility in Model 2. But again, this is a purely thrombolytic setting. Model 3 is what we call a standard hub and spoke, and this is what we have implemented in Tamil Nadu, and which is what we are implementing at the present time in states like Jharkhand and Gujarat. So you have a hub hospital, which does primary PCI. The spoke hospitals are linked to this hub hospital. Patients thrombolized in the spokes and then move to the hub for pharmaco-invasive treatment. The last model is where we have both private and public hospitals, and we call this a dual hub situation. So as we know, many of the government hospitals who get patients work to really capacity and sometimes are unable to handle these patients at different times of the day, or if they're full up with their routine cases. So we link two hospitals, both a private and a public hospital. So whatever overflow there is moved to the private hospital. But what we also do is to ensure that the private hospital that is part of this system utilizes, say, Ayushman Bharat or the local health insurance scheme so that the BPL patients are also catered. Now, why is it that we say that the STEMI India model is the ideal model, not just for India, but for low and middle income countries? And there are multiple reasons. There is robust scientific and economic data, some of which I just showed you. This model was developed in collaboration with ICMR and is today in India implemented by the National Health Mission. And so it comes with government support to implement this program. It's been endorsed by major scientific bodies, both within the country, the CSI, the API, the Stent Save a Life, the African Society for Interventional Cardiology. So multiple societies have endorsed this program. The protocols have been developed and validated in the STEMI program. There is a secure IT backbone for analytics. And this is important because we assure each state and each country that we participate with that the IT has multiple layers of safety so that patient data is safe and is localized within the country that the data is collected from. And there is, of course, regular training and quality audit. These are some of the papers that we've published across the world in very prestigious journals. This is the Heart, British Medical Journals, Global Heart, JAMA Cardiology, Circulation, and the Indian Heart Journal. Now, in order to implement this, early on, we realized that we would require to use digital tools to overcome some of the infrastructure and manpower deficiencies that exist in low and middle income countries. And so let me just show you some of the tools that we utilize. The first is an app called Cardiac Care, which is basically to improve patient awareness and help them to locate the closest STEMI accredited hospital. Now, what typically happens is when we roll out a program in a particular geography, we then encourage the local population to download this free app so that they're able to learn about the disease, to track their own medications, their stress levels, their exercise, their blood results. There is a way of contacting the ambulance in case one of them have chest pain. There is also an ability for us to locate the hospital that one needs to take these patients for. So it's available for free on Google Play. It's compatible with all Android mobile phones. It educates patients on symptom recognition, enables locating the nearest STEMI-ready hospital, enables calling for ambulance in case of emergencies, and provides reminders and alarms for medications. The second important app that we have is called the STEMI India mobile app. And what it does, it helps us to get the ECGs uploaded to the hub hospital. So there's both a similar app with the hub hospital doctor who can have a look at the ECGs, help them to diagnose the ECGs, and also utilize this for tele-ECG services. So typically, we use an ECG machine which has transmission capabilities, but we realize that sometimes these don't work. So you can use this app to take a picture of the ECG, and then it's transmitted to the service that helps you to diagnose. So this is basically something for the peripheral or spoke hospital. So there is a secure one-time login for hospitals and for cardiologists. It's compatible with both Android and Apple. It enables you to upload the ECG. There's an Ask Cardiologist feature to send the ECG for remote diagnosis either to the cardiologist or to a dedicated tele-ECG service. And once it is done, there are alerts that go out to the peripheral doctor to confirm that it is STEMI so that they can take immediate action. The third important digital tool that we have is a web application where data is collected. And this is so very important so that we are able to assess, to audit, and to improve on the level of care in the hospitals. So across the board, whether it's a peripheral hospital or a thrombolytic hospital or a PCI hospital, it's very easy to collect data, almost real-time data, so that we're able to ensure that the various timelines are maintained. So it's hosted securely on a cloud web. It's accessible through any browser on a computer with internet connection. It allows for recording of patient vitals, risk factors, thrombolysis, PCI timelines, in-hospital summary, discharge summary, and follow-up. Lastly, there is a tool which is called the dashboard, which gives a virtual real-time data analytics. So it will sort of refresh every 15 minutes, so you're able to see within your hospital or within the cluster, what is the number of patients who have been thrombolized, what are the timelines, and the various details that are there on the dashboard for immediate assessment of the data. So how does one go about implementing the program? And this is basically, I think, if you look at the elements of a system of care, there is the ambulance, there's the hardware, there's the software, there's the tool for ECG diagnosis, there are the protocols which have been developed, there's the training program, the analytics, and the governance. And this really totally constitute the STEMI system of care. So when we talk about implementing a program, we talk about two distinct areas that we help governments or private entities to implement a program. There is a clinical part and an administrative part. In the clinical part, we help in diagnosis. We have protocols for emergency care and treatment strategies, and we do training in managing these patients. So we give training not only to the doctors, but also to the paramedics and the nursing staff. And then there is the second part, which is to set up this whole system of care, monitor the key quality parameters, and do a gap analysis so that we are able to improve outcomes. So the training are both on-site and online. There's both protocol training, training for doctors, training for nurses, training for the paramedics, and the online training modules, which we give the doctors and the paramedics a self-paced way of continuous learning process. There is, of course, the more the administrative part to it, which is implementing the STEMI program, which is step one is mapping out the geography, cluster mapping. Step two, where we hire the personnel, procure the STEMI kits. Step three, where we go about installation, and step four is when the project goes into operations. We also ensure that there are weekly or monthly reports that go out to the hospitals, to the state governments, to the National Health Mission, so that they are able to assess how the program is working and look at areas for improvement. Finally, I think let me summarize the expertise and talk about future plans. So this is what STEMI Care does. Protocols have been developed. They do mappings, program setup, training, certification, using of the software, and project operations. So the whole gamut of running a STEMI program is done by STEMI India. Now, why does the STEMI India model work? It makes use of the existing resources by setting systems in place. There is a fair amount of flexibility allowing for adaptation according to the unique conditions. So we decide what would be the appropriate model in a particular geography based on various parameters. So model 1 might work somewhere, model 3 might work somewhere, model 4 might work somewhere. So we help the beneficiaries to understand what would work for them, and we help to implement it. It equips the field staff and enables sustainability in the long run through continuous training. And it's a modular and scalable across the state. So you can start with maybe model 1, and as infrastructure and doctors improve in their abilities, you can scale it up to a model 3 or a model 4. At the moment, the STEMI India protocol is being implemented in 3 states, and we had plans for another 3 states, but the COVID epidemic has slowed that down, and we hope in the coming year this will be a much more widely practiced program within India. Without or outside India, we are at the moment working with South Africa, but with our collaboration with STEM Save a Life, we envisage that many countries in Asia and Africa, particularly the low and middle income countries, we will be able to help them in running STEMI systems of care. What is the way forward? We plan to expand the program to include new clusters within the present states. We want to bring in the new states with funding from National Health Mission. The funding is already available, and we are in talks with multiple states to start implementation, and we hope that in the coming year this will happen. We plan to continue to work with SSL or STEM Save a Life and other African and Asian countries to help them run STEMI programs. But as a new initiative, and this is a platform that I'm reaching out to multiple cardiologists who work in big hospitals across this country, we are looking to work with the private sector hospitals in India to help run hub and spoke STEMI programs. And I would ask any of you who are interested in running a STEMI program to get in touch with us. And I'm sure we can help you to run the program. Thank you for your attention.
Maybe, Tom, we can go to the second lecture by Dr. Narula.
Yes, I think we should do that here.
It is indeed a pleasure to be able to participate in STEMI India, even though it is a virtual meeting this year. So thank you, Drs. Alexander, Malasri, Dr. Vander, Dr. Gersh, and Dr. Naber. This system of care approach for the ST elevation myocardial infarction in low and middle income countries. As we know that the burden of the cardiovascular disease in general and STEMI in particularly is increasing in low and middle income countries. These countries hold 80% of world's population, or almost 6 billion people. Accurate estimates of STEMI are lacking in low and middle income countries, but these could be upwards of 3 million cases each year. One of the recent report even suggests that there may be even about 2.4 million people in the India alone who may suffer from ST elevation myocardial infarction, and taking almost the same number from China, one could imagine that the number of 3 million may be just an underestimate. And the outcomes remain dismal in low and middle income countries. This is one of the reports from Salim Yusuf's group. And as you see that the major cardiovascular events, as well as the fatal cardiovascular events, are significantly higher in the low income countries as compared to the high and middle income countries. And not only that, the annualized case fatality rate after a specific cardiovascular event, as is shown here, is also higher in the low income countries. Here, the hazard ratio or the odds ratio of the case fatality is approximately 7 times higher, and the hazard ratio in the fatal cardiovascular events is approximately 6-fold higher as compared to the high-income countries. Predominantly, the annualized rates after the specific events is determined by the use of secondary prevention measures, which are dismally low in the low-income countries. As you can imagine, here the use of the ACE inhibitor and angiotensin receptor blockers and the use of the statins is less than 5% in the low-income countries. In the developed countries, the guidelines-based treatment, that is the rapid identification followed by the reperfusion, focusing on primary PCI as the reperfusion therapy of choice, and evidence-based supportive therapy with antiplatelet, ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists have dramatically improved the outcomes in patients presenting with STEMI. Although the guidelines are similarly applicable for the low and middle income countries, including Asia and Africa, and parts of the Central and South America, the challenges are entirely different. And extrapolation of these guidelines to low and middle income countries is not feasible and requires developing region-appropriate system of care approach. And that is where we all got together, including Dr. Chandrasekhar, Dr. Alexander, Dr. Malasri, and the people from various low and middle income countries. Approximately 40 of the authors, we got together to come up with a white paper, which was just recently published in Circulation. So the regional systems of care for STEMI have been virtually non-existent in the low and middle income countries. Cardiac catheterization laboratories are inadequate in number and are almost always clustered in urban locations. The transportation infrastructure is poor in these countries, which makes the access to the invasive centers difficult. There's lack of insurance coverage for the poor population, and the outcomes for STEMI are inferior in the low and middle income countries because of the downstream chronic morbidity, which also imposes a mammoth cost on the system. Even if you look at the Western populations, the time to the primary PCI is approximately 130 to 170 minutes on an average. And the socio-economic status and the logistics will not allow the Western-style throughput in the low and middle income countries. And that is why the increase in the peripheral decision-making and STEMI systems of care is necessary. The CREATE registry, which is specific to India, demonstrated that the range of the door-to-balloon time was 123 to 1,317 minutes, approximately 360 minutes being the average, which is the upper limit of what you see as the confident margin of time that is required for the myocardial salvation. The socio-economic and logistics will, as I said, not allow the Western-style throughput, because even in the US hospital, there are only about 25% of them which are capable for performing the primary PCIs. And delivering the therapy specifically is still a challenge even in United States. Door-to-balloon time of less than 90 minutes is achieved by about 50% of the patients, which are done in less than 90 minutes, and door-to-balloon time of less than 120 minutes for the transferred patients. If we keep in consideration, only about 10% of the people would be treated in 90 minutes, and 15 to 35% of the people will be treated in 120 minutes. Even in the best of the places, such as the Minneapolis Heart Institute, which is the level 1 MI program in the country, 66% of the people are treated in less than 120 minutes, and approximately 8% of the people need more than 3 hours time for the primary PCI in these cases. But as the CREATE registry had demonstrated, that there is still a hope for the better treatment of STEMI in the low and middle income countries. For example, currently only about 8% of the people receive the primary PCI, and the mortality rate, which is adjusted for the risk factors and location of infarct, the likelihood of having the odds ratio is approximately 1.5. But there is a possibility that one may be able to reduce because of the systems of care approach. Now, what are the choke points and what are the action points for the ST elevation myocardial infarction in low and middle income countries? And we can imagine that they are at every single level. Some of them are patient related, some are logistics related, and some are healthcare infrastructure related. And there is a need to improve at every single level. So here I have tried to recognize the various choke points, while here are the solutions in the bottom. For example, what do we really need to do at the level of the patients is the education, whether we use the advertising media or we use the social media. The logistic related changes required are the policy changes, the investment in the emergency medical services, infrastructure, legislation, and systems of care, while the healthcare investments which are needed are for the low-cost electrocardiograms, the Center for MI Care and the thrombolytic therapy, the systems of care and audit, and the quality assurance measures. So, is there a possibility that we are able to create the level of facilities here and designate the facility levels and spread the word, create the networks with various levels of expertise, incentivize facilities which will be quite like the primary health centers or the general practitioners, which will be the level 1 facility where at least the patient gets the first attention and even the electrocardiogram may not be available. The level 2 facilities are, which could be the community health centers or which will be the doctor's office where the electrocardiogram could be performed and at least the diagnosis of STEMI may be made, or the electrocardiogram is at least able to be beamed to the higher level of the centers. Level 3 would be where the thrombolytic therapy is available all the times and the PCI may be partly available or may not be available. And the level 4 are the facilities which are equipped with 24 hours PCI. And then we all need to bind this up into a system of care approach. So if we talk about the level 1 facility where only the doctor or the other healthcare workers might be available, the electrocardiogram may not be available in these places, but at least the patient's history could be taken and some idea of the likelihood of MI could be made. And if confident, we should be able to deliver a chewable or soluble aspirin 325 milligram stacked to the patients. And after that, we could transfer them to the next level of facility. If the suspicion is high, send them to the level 3 or level 4 hospitals as the proximity may allow. But if the likelihood is not high, then we could send them to the center where the electrocardiograms could be done. Level 2 are the facilities which are equipped with the electrocardiograms or which are capable of electrocardiographic facility, and there within 10 minutes of arrival of the patient, one should be able to identify whether the patient has ST elevation myocardial infarction. If the diagnosis is made, then the patient should be given the chewable or soluble aspirin if was not given already, the clopidogrel, the dose specific to the age, and the high dose of statins are delivered and the patient is sent to the nearest reperfusion center, be it thrombolytic therapy or the PCI in these cases. The level 3 facilities will be those which, after the patient arrives and if the diagnosis of the MI was already confirmed, the patient should be able to get the thrombolysis. And then after the thrombolysis, within 90 minutes, the ECG should be performed, and immediate transfer should occur if the thrombolytic therapy failed. But if it worked, then we should stabilize the patient, and the transfer could occur in next 3 to 24 hours. The transfer to the level 4 or a direct admission to level 4 could happen. The transfer may happen from facility level 1, 2, or 3, or there could be a direct transport of the patient to the level 4 facility, where the patient is subjected to the primary PCI, even in those patients where this thrombolytic therapy might have been given. So here, essentially, that approach has been summarized as to how the patient may move from facility 1 to 2 to 3 to 4, or maybe from 1 to 3 to 4, or maybe directly to the facility level 4, and it would require understanding and the development of the infrastructure. Then what are the recommendations from the governments and the non-government organizations in the low and middle income countries? And they are obviously towards the infrastructure development, and they are predominantly related to the ambulance service as to what would be minimally required, what would be ideally recommended, and what would be an aspirational goal in these cases. The second is, how do we obtain the electrocardiogram? And again, minimum, ideally, or aspirational recommendations. And finally, the presence of the troponin or other biomarkers as needed. The recommendations for the governments and the non-governmental organizations also include creating locality-appropriate systems of STEMI care, the strategies to shorten the time to care, and creating locality-appropriate reperfusion strategies. Even though we are able to do that, and even though we are able to develop these infrastructures in the low middle income countries, the focus must remain on prevention. We must ensure that we prevent the disease rather than waiting for disease to happen and then using the infrastructure to deliver the treatment for ST elevation myocardial infarction. We should have the education and awareness so that people are able to understand their symptoms, they're able to recognize their symptoms, they are able to understand the gravity, and they are able to understand the urgency of seeking medical care. And then we also require the level of care designation for various facilities. And also, can we alter, modify, or tweak the traffic rules so as to have a free flow of the ambulances to the appropriate centers. The ECG facilities and telemedicine needs to be consolidated. The aspirin strategy needs to be developed and adapted. The pharmaco-invasive approach and the preferred bolus fibrinolysis that needs to take place. We need to reinvigorate the myocardial protection strategies, which used to occur earlier when the reperfusion strategies were not available, such as the use of beta-adrenergic blockers, even though it has recently landed into some of the controversy. But the possibility is that they are able to prevent the adverse outcomes, and they are able to reduce the likelihood of a large infarct size. And then, most importantly, it is needed that we have the, as much as possible, we have the secondary prophylaxis for the occurrence of the recurrent events, number one, or the occurrence of the complications of ST elevation myocardial infarction. Thank you.
where the delays before you get the electrocardiogram. And there has to be a way of getting that ECG and interpreting it much more quickly, even if it's not interpreted on site. So I think this is an area where I would see maybe machine learning, but certainly digital technology, telemetry being developed, as actually Dr. Narula did talk about telemetry.
Yeah, let me just tell you that we have now developed a tele-ECG service that we're now using in our rural setup. And it goes through 3 phases, actually. It goes through an AI first, and then it goes, very often the AI is adequate to make the diagnosis. Then it goes through a qualified ECG technician who looks at it, and then he has the freedom to then escalate it to a cardiologist if required. But often, just the AI and the ECG technicians is enough for the diagnosis and a return to the patient. To the person who's done the ECG, and this turnaround time of 5 minutes is what we assure the centers.
Outstanding.
Shireesh,
I think in India the technical development is really very good, and even going up to the remote villages. What we lack is government support, and unless and until that is there, it is a huge task to cover the whole of India. So as and when we start getting good government support, I think we can implement all these ideas in various states.
I think, Shireesh, I think that's a very important point, but there is a sense of urgency from the government that we see now. And at least in STEMI care, we see that the National Health Mission has a significant funding for it. But what we see is the lack of political will in many of the states to take it forward. Ajit?
Yeah, I agree with you. I think the states which seem to have the political will, I think, will push this through. All we need is a program set up with some local leaders, which is very easy because many cardiologists and many physicians are very happy to lead the program. But the biggest stumbling block is the government's will to start the program and continue it. I don't think it's the money. It is just they're so much caught up with so many other things that STEMI seems to not be on their bandwidth as the first option. But I think that we're slowly getting in, at least some of the southern states, and we're getting it in Gujarat now. And even Jharkhand, we are very positive about what they've done in Jharkhand, which is a small state and not very developed like the southern state. So I think this is all positive. And I think that with NHM help, we should be able to slowly reach out and get more and more information and more data.
Thank you, Ajit. And I think to everybody, I think there is a paper in circulation that's come out within the last 3 months, which talks about infrastructure, the low and middle income countries and the way to take the STEMI program forward. So I would recommend that this is a very important document for countries in low and middle income countries to look at how they can develop systems of care. Okay, I think it's time to move on to the next talk. Dr. Christoph Naber from Germany, who heads the Stent Save a Life program. Again, this is a global program that is affiliated to EuroPCR, where he works with us. He's an associate professor of medicine at the University Hospital Essen in Germany. But more importantly, he's the chairman of the Stent Save a Life, an initiative which currently has close to about 40 countries from across the world, which are looking at ways and means of developing systems of care, STEMI systems of care. And I have the privilege and the pleasure to inform everybody that the STEMI India model has now been recognized by this group as the global model for low and middle income countries. And we are in the process of starting many of these programs in these countries. So let me request Christoph Naber to talk about the importance of time to treat.
Yes, hello, dear friends. It's a pleasure and an honor to be invited to speak at STEMI India. And I'm really grateful to my dear friend Thomas Alexander and the team of STEMI India. Now we're speaking in STEMI about the importance of time to treatment. I think we know most about that. We know why it's important. The reason is simple: time is muscle. What happens in a STEMI? A vessel is occluded, and we see this in the top panel here. Then we have a scar developing, and the longer that the blood is not flowing and there's no oxygen coming to the heart muscle, then we will have a permanent damage, which can result ultimately also in an aneurysm, but in a dysfunctional part of the heart, which is irreversible. Now, this is a slide from the guidelines, and you know that the guidelines in STEMI very much focus on time. So if you look at the guideline, you see the path of the patient having chest pain, and then going either to a non-PCI center or a primary PCI center, or contacting the EMS service. But all these, over all these, we have the timeline. After the patient enters the hospital or calls on the emergency first response, then the patient goes to either primary PCI, fibrinolysis, or primary PCI if he goes directly to a primary PCI center. Now, as I said, the timeline is underlying and overlaying of all this process. And we decide, we name this time the total ischemic time. This is a time from the onset of symptoms to the final treatment. And if we look at this time, it is better if it's shorter. So we are speaking about delays. And we have one delay, which is the patient delay. This is everything that the patient does to delay his time to treatment. And then we have the system delay. So everything that is in the system to delay the time to treatment. Now, what is the best therapy? We all know that it's primary PCI. And to send the patient to primary PCI from the time that we have, that he has the symptoms, we should have no longer than 120 minutes. This is what the guidelines say. If it is longer, we should go for a strategy which is a combined fibrinolysis and then rescue PCI approach. So time plays an important role here as well. Now, what are the factors of the total ischemic time? I told you one is the patient delay. Then, if we have an EMS service, the EMS can also cause delay. If there's no EMS, we might even have some more delay. Then we have to see, is there a transfer in the hospital to the cath lab? Is there a delay in the hospital emergency unit until the patient receives lysis? Or if we can send the patient to a cath lab, is there a delay until the cath lab is ready, or how the colleagues will finally treat the patient and cause also a delay? I will not speak about the time in the cath lab. Let us just speak about the delays that happen before cath lab. Now, patient delay. And these are data coming from Portugal, but you will see that these data are very similar to many other countries. If we look at the total ischemic time in Portugal, it was in that year 250 minutes. If we look at the part of the patient delay, it's almost 50%. It's 108 minutes of the median treatment delay time. Then, if the patient has an EMS service and he calls the EMS service and the EMS service brings the patient directly to a hospital, then we have only 50% of the delay time that is called the patient delay. So it's much better if we have an EMS service that the patient can call by one number, which is in Portugal the 112. So one significant factor which prolongs patient delay time is if the patient first goes to a primary care unit which knows nothing about STEMI care. In this case, the patient delay time is prolonged by another 50%. So it is almost 60 to 75% of the time to treatment. And it's 163 minutes. This is only patient delay. Now, these are some factors which contribute to patient delay. One big factor, at least in Portugal, is the age. And this is something that we also observe in Germany. A second factor is the symptom onset between midnight and 8 o'clock in the morning. Also here, we have a significantly longer patient delay. If the patient, as I told you, calls 112 or calls an EMS service, which is able to bring him to the therapy or start the first therapy in case of lysis, then this time is significantly reduced. And if the primary care unit is attended before the first real medical contact, then the patient delay is prolonged. If the patient goes to the primary PCI facility or seeks medical attention by own means, then the patient delay is significantly longer. When there is an organized EMS transport of the patient to the primary PCI facility or to lysis, then this time is significantly shorter. Now, we see that an organized EMS service is very important. And I know that we all focus a lot of attention to coordinate the EMS services in the areas where we treat. Here, what we see here in this graph is, and this is from a meta-analysis with 125,000 patients, we see that patients who are treated in a short period of time, so patients who are treated within 90 minutes, that was the point in this trial, have also a significantly shorter transportation time, expressed here as first medical contact to door time in the hospital. So we need to bring the patients faster to the hospital, then they will also be treated earlier. This seems almost like a simple knowledge, but when we look at the same trial, and don't have the data here, is that especially for lysis, and this will be something that we see often in countries who do not have primary PCI for everybody. Then we have a significant correlation between transportation time and mortality if we speak about a combined lysis and PCI approach. Now, EMS service. What should an EMS service do? And here you see a breakdown from different EMS services in several countries. These are mostly Western countries like United States, Canada, Denmark, Netherlands, Germany, United Kingdom, and Australia. But you can see that already in these countries, the time from the first contact of the EMS service to the delivery of the patient to the door of the hospital varies between 40 minutes and 60 minutes. So you see that it's very important what the EMS service does. And we can see that the response time is mostly around 10 minutes. But it is there's a lot of importance of what the EMS service does when they see the patient for the first time. Here we have a lot of variety. And what we believe nowadays, and if we look in the new guidelines, is that the best is that the patient is immediately taken to the place where to his final therapy, which can be either primary PCI or which can be lysis if the way to the primary PCI is too long. So there shouldn't be too much stabilization of the patient before the treatment starts once the diagnosis of STEMI is established. Now, here you see what I was just talking about. You can see here, when we speak about primary PCI, there is a trend of the transportation time being connected to mortality, but this is strong and significant if we speak about a combined lytic and PCI approach. Now, what happens when the patient comes to the hospital? Also here, we need very good organization. We know that if the emergency physicians already activate the cath lab, then we can spare about 8.2 minutes of door-to-room time. If one single call activates the cath lab, we have 13.8 minutes time that we can save from the door to the final treatment. If we activate the cath lab before the patient arrives, we save 15 minutes. If the rule for the staff to arrive in the cath lab is less than 20 minutes, then we save 20 minutes of time. So if the attending cardiologist is on site, we save 15 minutes of time. And if we have a real-time data feedback, and this is very important because this is one of the tools that also Thomas Alexander uses in India, in STEMI India, real-time data feedback saves another 8 to 9 minutes of time. Now, if we look how many of the hospitals have installed these key strategies, then we see from the same publication, we see that 137 of the hospitals, which is 37 or 38%, have none of these key strategies installed. Only 8 hospitals, which is 2.2%, have at least 4 of these key strategies involved. So I think organization in the cath lab, which is something that we entirely have in our hands, is something that we really can do in order to improve drastically the time to treatment. And this is something each of us needs to ask himself if the organization within the hospital is optimal to treat patients with STEMI. Now, how do we organize STEMI networks? And there's nobody better to tell you than Thomas Alexander. So many of the things I tell you here are we have worked out together with him at Stent Save a Life. Now, what we know is that there are 5 players in the STEMI network. This is patient and family, GP, GC, the EMS service, primary PCI centers, and non-primary PCI centers. We need to take all these players and need to see how is the distance, how is the relationship, can an EMS service be where, in which time. And once we know how this can be organized, we can organize a kind of, which is called the hub and spoke model, which is used in the STEMI India model. This means that we have different hubs in the region from where the patients are then transported, for example, to the primary PCI center, but first they are collected there because we do not have primary PCI centers enough in all of the countries. Now, how do we organize that? We have to map our resources, and this is a map of the Bavarian Forest where I was raised. And you see we have here primary PCI center, we have EMS services, we have some non, and then we need to measure the distances and add the resources and give them their specific tasks. Now, if we have no primary PCI facilities available, what to do? Well, we said we have 3 strategies. The first strategy is primary PCI. The second strategy is facilitated PCI. And the third strategy, if we have nothing that we can offer in terms of primary PCI, then we should at least organize a kind of lysis network so that the patients are treated quickly with lysis, because lysis is much better than doing nothing on STEMI. Now, my summary is all players in the STEMI network have to work as one in order to shorten the time to treatment. A well-coordinated STEMI logistics reduce time to treatment. But the patient delay is very significant. So patients need to know that symptoms of a STEMI require immediate medical attention. And every STEMI must be treated. PCI is standard of care, but if PCI cannot be made available, the pharmaco-invasive approach, which is done in many regions in the world very successfully, is a very good approach. And even standalone thrombolysis would be better than doing nothing in order to save lives. So I thank you very much, and I wish you a successful conference.
I think it's tremendously important for us to realize that across the world, people are looking, especially in low and middle income countries. I think there is a sense of urgency to develop STEMI systems of care. And with the explosive growth of NCDs and the recognition that STEMI plays a major part in the mortality of NCDs, I think countries across the world are looking for solutions, and we've been privileged to be part of this global network that is helping utilizing our model to help other countries across the world. So can I just go down the line and ask for comments? Shireesh?
Yeah, I think the major stumbling blocks in India are two in terms of delay. If we can divide delays into pre-hospital and in-hospital delays, the pre-hospital delay is basically awareness and the patient-related delay. And in-hospital delay, I would divide into two: the door to decision delay and the decision to cath lab delay. I think door to decision is economic constraints. So the main stumbling block will be patient delay and economic constraints, so door to decision. So I think if we concentrate on these two delays, I think we can definitely improve the STEMI care systems.
I think, Shireesh, I think that's tremendously important. And this is why we talk about accessibility and equity. And in countries like ours, I think the poorest of the poor should have access to some form of reperfusion, and that's critically important. Rajat?
Yeah, well, I think that the most important thing is some sort of an insurance which is equitably available to everybody to access care, to an ambulance service which will take care of the EMS issues. And finally, a combined approach of using thrombolysis and primary PCI, either standalone primary PCI, lysis plus minus a pharmaco-invasive, and using that judiciously without delay. And that is the key, I think, to make decisions to improve outcomes. And I think that the model that we did in Tamil Nadu, if it could be polished and replicated, I think many problems can be sorted.
Thanks, Ajit. Bernard?
Yeah, I think, all around the world, the problem is the same. How quickly can we get people to reperfusion therapy? The solutions will differ because of regional issues and economic issues and climate issues and so on. And that's really going to be what I'll talk about in terms of the pharmaco-invasive strategy. But the problems are the same, and how you solve them is going to be local. I wanted to go back to something that Dr. Narula said in his last slide about prevention. So one thing we're seeing in the United States and Western Europe is, 10, 15 years ago, myocardial infarctions, the STEMI, dominated what we saw. And now, by far and away, non-STEMI is the commonest form of myocardial infarction. In a population-based study like Olmsted County, we looked at this in Minnesota. But this has been seen in many other places. Now, we don't quite understand why, but I think a lot of this is statins, maybe plaque erosion instead of plaque rupture. Statins, I think aspirin for secondary prevention. Large numbers of people out there have already had bypass surgery or PCI. Control of risk factors, not sure what it is, but it has been very interesting to see the decline in STEMI, not that it still isn't a problem, of course it is, but the decline in STEMI and the increase in non-STEMI. And in terms of equity, I'll make one comment. I published a paper with Suni Rao from Duke several years ago. And we looked at a Medicare database, and we called it, the title of the paper, subtitle was Health is Wealth. So in the United States, the results of myocardial infarction differed according to the zip code you live. So if your zip code corresponded to the lower third of income, your mortality was 10% higher compared to those in the middle income group. If your zip code corresponded to the top third of income, your mortality was 10% lower. So wealth is health. There are inequities. I think they're everywhere. I think they're very much present in the United States. But even in single-payer systems, recent studies coming out of Denmark have shown that in certain other conditions, not necessarily STEMI, but even in a single-payer system, there's a income and socioeconomic status dominate outcomes.
Thanks, Bernard, for those very perceptive comments. I'm going to jump to Gurpreet, and then Christoph, you can summarize the discussion. Gurpreet, your comments on?
I found what Dr. Gersh said very interesting, because the CREATE data showed the same actually. If you look at the rich and the poor, there was significant, about 3% mortality difference in terms of people getting thrombolized, and the mortality gap was so significant between the rich and the poor in this very large Indian study also. And as he said, we still have, Dr. Mulasri and Thomas, you'll bear with me, we still have actually the ratio of STEMI to N-STEMI as 60-40, as against most Western countries where the N-STEMIs are higher than STEMIs. So maybe there are some factors, like he said, more people on treatment in the Western countries. But one thing I would like to emphasize is that the fact that you people have taken upon looking at the systems of care in terms of acute myocardial infarction, I think that is one of the most significant contribution, because as cardiologists, we are always so centered on our own job, whether we are doing it well or not, that we forget that what makes a bigger difference actually to their mortality is development of the systems, which somehow takes second stage. And ever since we started participating with the STEMI India in our center, our systems have improved more significantly than anything else. So I think that's a huge contribution to the care of these patients.
Thank you, Gurpreet. I think when we talk about equity, we also need to remember the male to female ratios and the huge inequity that is seen in women who present with STEMI. And I think that's a topic for another discussion. So Christoph, maybe you can just sum up before we go on. Thank you so much, Christoph, for being part of this meeting. I think it's wonderful to see you.
Thank you very much, Thomas. It's for me an honor, and I would like to be with all of you in person, but it's not possible at this time, so it's very good to hear this discussion. And I couldn't say more than Dr. Gersh Bernard just said at the moment, because I think he summarized something very, very important, which should be the brackets around this discussion. This is the organization of systems of care. If we have great therapies to offer, and what we shouldn't do is we should not just wait until we have the optimal therapy like primary PCI for all patients, enough cath labs and all these. Whatever we have, we should organize it in a system of care and offer it to our patients. And we can start very simple with lysis. We can start with a combined pharmaco-invasive approach, and then we could go to primary PCI for all patients. But there is no excuse for all of us, wherever we are in the world, and I think India is making a really great effort and a successful effort to show that wherever you are, in whichever situation you are, you can make a fantastic network to support your patients. And we see in all these different states where STEMI India is now implementing these STEMI networks and systems of care, we always have, and we have this discussion frequently, we always have very different circumstances, very different conditions. And you can adopt these networks to wherever you are. And this is true for Africa, for entire Asia, for Europe, and even for the places everywhere in the US and South America. So I think this is the most important thing. Systems of care, organization of whatever we have, and there's no excuse to do nothing. Thank you very much.
Thank you, Christoph. I think we can now move on to the next talk. We're talking about the fourth universal definition of MI, and we have with us Dr. Gurpreet Wanda. Dr. Wanda is from Hero DMC Heart Institute, but I think for Indian audiences, he requires no introduction at all, a giant in the field of cardiology. Dr. Wanda.
Let me thank Dr. Ajit Mulasri, Dr. Thomas Alexander, and Dr. Sathe
for giving me this opportunity to participate in this very important conference, STEMI 2020. The task assigned to me for today is to discuss about the universal definitions of myocardial infarction and to see what is the clinical utility of this new definition. Actually not so new, it's been there for last 20 years. We'll just discuss how does this compare with the usual definition of MI that we take. And my greetings from state of Punjab, from the city of Ludhiana. This is what, as clinicians, we are all used to actually classifying patients who come to our emergency with acute chest pain, and we do their electrocardiograms. There is some ST segment changes, and we classify them depending upon the ST changes into STEMI, NSTEMI, or unstable angina. If the patients have ECG changes, but there are no biomarkers elevation like troponin T or troponin I, we call it unstable angina. But if there is no ST elevation, props are elevated, it is NSTEMI. And if patient has an ST elevation, then of course it is the usual acute myocardial infarction patient which comes to our emergency, and it starts the whole cascade of activities. We either thrombolize them or we take them up for a primary PCI depending upon what kind of a facility these patients come to. This actually is the usual common garden way we classify patients who come to us with the emergency. But the universal definition of myocardial infarction, which was actually the 4th revision, came in 2018. I'll just spend next 10-12 minutes discussing. The whole thing started actually in the year 2000 when the European Society of Cardiology, the American College of Cardiology started combined definition of acute myocardial infarction, because they realized that myocardial infarction is not just of the plaque rupture, formation of a thrombus, and whether this thrombus results in a complete occlusion when it is STEMI or in an incomplete occlusion when it is an NSTEMI. There are various other actually subsets of this myocardial infarction, which is characterized by myocardial necrosis because of ischemia. And that's how this definition came up in the year 2000. Then the universal definition came up when the NHLBI also participated. The World Heart Federation came up, and the WHO actually accepted this new way of definition. The third one came in around 2013, and this is the latest what we are discussing. But we all know the WHO definition of chest pain, STT changes, and biomarkers. At that time, CPK-MB was available. Now we depend solely on troponin T and I because they are more specific to the heart. And so this is actually the genesis of these two kind of definitions that we take. The universal definition essentially looks at two things. There should be elevation of cardiac biomarkers, which is, I feel, the central thing to this universal definition. And along with this, if you are able to define myocardial ischemia, whether you look at it, the ECG, or you look at the echo or some radionuclear methods, and you find ischemia is there, wall motion abnormality is there. So biomarker elevation with ischemia is myocardial infarction. Biomarker elevation without ischemia is myocardial injury, if I have to put it in a simplistic manner. And myocardial injury is actually defined as elevation of troponins above 99th percentile of the upper reference limit, which is there for that population. And myocardial injury, you people have been listening a lot to this actually in this COVID era, because we know myocardial involvement occurs in patients of COVID-19, and it is a marker. Troponins, whenever they are elevated, we had initial data from Wuhan also that even patients without heart disease who had elevation of troponins, they had higher mortality, and those who had coronary disease with trop elevations, they were in fact even worse off. Many times my residents and my colleagues are at times called by doctors in the ICUs in post-operative phase, and they do a troponin and they say that the patient has suffered a myocardial infarction. Our resident goes there, does an echo shows no wall motion abnormality, and they say that they are just doing troponins which are falsely positive. But that is not the case now. We realize that these what we have been calling as troponinemias or troponin leaks. They are equally important in those patients where there is no ischemia, there is no infarction, and where there is no ST elevation or Q waves, because it is also a marker of increased mortality in these patients. And so all troponin elevations have to be paid heed to. And this is exactly what these fourth UDMI definition actually, it does distinguish between myocardial infarction and injury, but it places myocardial injury in its right perspective. Of course, there is some discussion on how cardiac MRI can help us, because ischemia is subendocardial and myocarditis tends to be subepicardial. So location of these abnormalities will be able to tell us what kind of injury your patient is having. And every troponin elevation we know is not myocardial infarction, but it is something that, in fact, the main purpose of this talk is to emphasize that troponin elevations are not to be ignored, even if they are not associated with infarction or wall motion abnormalities, because they are markers of increased mortality. They are markers of bad prognosis on a long-term basis. Of course, we know chronic conditions like chronic kidney disease, heart failure, they can all be associated with troponin elevations, but acute cardiac conditions other than ischemia like myocarditis, Takasubo's disease, cardiac procedures like CABG, ablation, even giving a shock, actually all these can lead to myocardial necrosis, and thus it can result in troponin leaks. We also know patients who are critically ill in ICUs when there is strenuous exercise, patients with other diseases like embolism, stroke, subarachnoid, they can all have troponin leaks, and they all need to be paid heed to, because it is a marker of acute myocardial injury. And this is one big difference between the UDMI-3 and the universal definition of myocardial infarction 4, because here we are making a distinction between acute and chronic myocardial injury. Now, various disorders, whether someone has anemia or arrhythmias or hypoxemia or shock, they can be associated with no troponin leaks, of course we know, but some of these people can have troponin leak, but they may not have any ischemia documented, when we will call it as myocardial injury. But if there is a ischemia which you are documenting, then of course it is a myocardial infarction. So as I said earlier, at the cost of repetition, I would say troponin leaks with ischemia makes it myocardial infarction. Troponin elevation not to be ignored even if there is no ischemia, because it is a marker of myocardial injury. And if there is no troponin leak, of course we know there is no myocardial injury. So as I said, if someone has troponin raised and there is ischemia, it is acute myocardial infarction. And if it is based on a plaque rupture, we call it as type 1 myocardial infarction. But it is this type 2 myocardial infarction which occurs because of the imbalance between the supply and demand, because of hypertension, arrhythmia, various shock, hypotension, hypoxemia. That is what actually makes a diagnosis of type 2 myocardial infarction. And of course, myocardial injury can be acute when there is a rise and fall of troponin levels, like in acute heart failure, and it can be chronic, like in chronic heart failure or in chronic kidney disease. So these are largely these 4 subsets: type 1, 2 MI, and chronic and acute myocardial injury, what we have. And this is what you actually see every day in the emergency. Plaque rupture occurs. Why it happens is known to us to some extent, but not fully, because of strenuous exercise, physical, emotional stress. And plaques that rupture are, of course, thin fibrous plaque with the heavy inside core. And once they rupture, mostly at the edge, that is when thrombus forms, and these patients come to us with acute myocardial infarction. But type 2 myocardial infarction is something that you and I need to pay more attention to and diagnose it more often, because we know these patients can be based on a vasospasm, on a dissection, or there can even be a normal coronary, or there can be a very severe atherosclerotic disease, almost 99% lesion, and they become precipitated by anemia, or patient has GI bleed, shock, hypotension, hypoxemia, and that's when this imbalance occurs. There is no plaque rupture of the myocardial infarction type 1. So the type 2 myocardial infarction can actually be secondary to another illness, or it can be the main actually presenting feature. And it could be due to a spasm, embolism, dissection, arrhythmia, or severe hypertension, or it can only be because of one of the systemic factors like respiratory failure, anemia, hypotension, shock. So type 2 is a diverse kind of a myocardial infarction. You will have to place your patient into one of these. I will come back to this type 2 and myocardial injury issue because I feel this is the most important aspect. But I'll finish off with type 3, 4, and 5 myocardial infarction in the universal definition of myocardial infarction quickly. Type 3 is when your patient dies actually with some ST changes, chest pain, but before biomarkers have even raised or you have been able to detect. And so this is to distinguish it from patients of sudden death, because we know here there is an ischemia, which is a major factor. So this is type 3. Type 4 is of 3 types. Type 4A is when you're doing angioplasty in your patient, there is some side branch occlusion, or there is no reflow, slow flow, and you find that the troponins are going up, and we know this is a marker of high peri-procedural risk. And along with that, if you have ECG changes or wall motion abnormality or angiography showing, so one of these 3 with troponins, and peri-PCI troponin elevation of more than 5 times the upper reference level, and post peri-CABG it has to be 10 times the upper reference level. So type 4A is while you're doing a procedure. 4B is stent thrombosis occurring, and this could occur acutely within 1 day or subacutely within 1 month, or late when it is between 1 month to 1 year, and very late we know our patients with the what you call the paclitaxel stents, the taxa stent, we all know very late thrombosis was happening, and that's what we saw at that time. So stent thrombosis, it's a bad condition, it carries significantly higher mortality, but here coming back to the classification, this is 4B. 4C is when there is restenosis and your patient has actually troponin elevation because of severe restenosis. So these are the type 4, all related to PCI, but peri-procedural, stent thrombosis, and restenosis related. And type 5 is when it is related to CABG, and as I said, as against PTCA here, 10 times increased elevation. Of course, ischemia has to be documented based on ECG changes, angiography abnormality, or wall motion abnormality. So coming back to the main issue that we actually have in this universal definition, does this issue of myocardial injury add significantly to our knowledge, our practices, and our risk stratification of patients? Well, surely, because if you look at the time and the events rate, you find that various types have, with myocardial injury, there is a significant difference in mortality. There is a significant difference in short-term and long-term prognosis, what I'll talk to you in the next couple of minutes. Because we know the primary illness could be cardiac, and if it is a atherothrombosis or acute atherothrombotic episode, plaque rupture, we call it as type 1. And if it is acute but not a rupture but a spasm, embolism, microvascular endothelial dysfunction, intramural hematoma, all this will constitute as type 2, or it could even be non-primary, non-atherosclerotic hypoxemia or something of that sort, which is causing a type 2 myocardial infarction. But we do know whether it is type 1 or type 2. In both these, it could be STEMI or NSTEMI. The presentation could be either of the two. And the continuum of atherosclerosis, you could have a mild, moderate, or severe atherosclerosis in type 1 or type 2. And myocardial infarction with no non-obstructive coronary arteries could be actually seen. The MINOCA could be seen in type 1 or type 2 MI. Now, this particular group with Avaninder Singh actually looked at younger patients on a long-term, very beautiful study published this year actually in the JAC. They have looked at young people and compared type 1 with type 2 myocardial infarction and looked at how does it affect the prognosis. Of the total 4,000 patients, almost half were type 1 MI, but a significant 1/3 of their patients were type 2, and 13% had only myocardial injury, no ischemia documented. And what they found was that the type 2 MI patients were younger, they were women more often, the cardiovascular risk factors were less, and non-cardiac comorbidities actually were much higher. And obviously the cardiovascular drugs were being given less often. But this is what we come to something interesting here. the in-hospital mortality was highest in the myocardial injury patient. The mortality in type 2 myocardial infarction was much higher than in type 1 myocardial infarction. So type 2 MI myocardial injury carries a higher in-hospital mortality. They looked at the 10-year follow-up, and what you find is something equally interesting. The cardiovascular mortality was similar, but the non-cardiovascular mortality over 10 years was much higher in this subgroup of patients. Of course, we had multiple causes, and we know sepsis, arrhythmia, hypoxemia, all this can be responsible for myocardial injury or myocardial ischemia both. And Dr. Hartikainen looked at, actually, if you look at the third and the fourth universal definition, a lot of these patients now can be classified into acute myocardial injury, which carries a higher mortality. Hazards ratio is much higher than the chronic. So make a distinction in myocardial injury also between acute and chronic myocardial injury. This is another study published in 2020, Circulation. Again, it shows that all-cause deaths are highest in acute myocardial injury, somewhat significant in chronic myocardial injury, and also significant in patients with type 2 and least in type 1 myocardial infarction. So these are some of the new things which have been added in the type 4. And I would end here, friends, by making some statements which I feel that this universal definition of MI is centered essentially around the cardiac biomarker, the troponin elevations. It distinguishes between myocardial injury and infarction, and we need to make this distinction in our mind. The troponin elevation that you get in acutely sick patients is not to be ignored, because as I showed in these two beautiful studies, their prognosis, short-term and long-term, is worse than type 1 MI. And we have to place them, depending upon whether there is ischemia or not, into injury or type 2 myocardial infarction. Then we also know that patients of type 2 myocardial infarction, as I showed you, have a bad long-term prognosis. And this subclassification of myocardial infarction into 5 categories helps us to place in perspective as to what particular situation a patient of myocardial infarction has had, and also what is the short-term and long-term prognosis of these patients. So the universal definition of MI has come to stay, and this is something that you and I are going to use it on a long-term basis, and it helps us in our clinical judgment in looking at what situation our patient had infarction and what was the precipitating factor. Thank you very much.
Fantastic talk, and I think it re-emphasized to all of us the importance of type 2 MI. And I think in these COVID times, when we see both type 2 and type 1, I think it just emphasizes how important it is for us to recognize type 2. So again, let me just go quickly through the panelists here. Dr. Gersh, do you have any comments? You're muted. Yeah.
No, not really. I mean, it's an excellent talk. And I think the whole concept of type 1 and type 2 myocardial infarction is, it's not just relevant to the STEMI program we're at today. I mean, this really is a difficult area, particularly with type 2 infarcts in relationship to procedures. I mean, we right now are going through a big controversy about the results of PCI versus bypass surgery in left main coronary disease. And the controversy is fueled to a very large extent, I think artificially, by the definitions of myocardial infarction. So if you make the definition of type 2 myocardial infarction or peri-procedural infarction, if you lower the criteria, you will have more infarcts. And but they'll have less effect on prognosis. If you make the criteria more stringent, you will have fewer infarcts, but they'll have a bigger effect on prognosis. So what really is an issue is, do you have one type 2 definition for post-PCI myocardial infarction and a different definition for bypass surgery? And if you do, it's going to lead to all kinds of artificial differences between the two procedures. So it's an interesting area, and it was an excellent talk. Thank you.
I think this is an important point that you raised about the Excel trial, and definition, whether you should use a SCI or the universal definition. And I think we could have a full day discussion on this.
Thomas, about 2 hours from now, I'm doing virtual grand rounds at Mount Sinai in New York. I'm doing grand rounds in Mount Sinai in New York tomorrow at a different hospital today. And I'm going to talk about stable coronary disease and revascularization, because I'm very involved with the EXCEL trial and the rebuttal. And so this is a personal issue, and I will be addressing it and hopefully get the chance. Oh, no, I'm going to talk about it again at CSI.
Okay. Christoph? You're muted, Christoph.
Yeah, excellent talk, I have to say, and it's a very interesting topic. I think what we learned from this discussion, and also from Bernard Gersh's comment, we have to understand that, well, number one, to have a definition which is called universal and which is accepted by all of us more or less and discussed, this means that we are all speaking about the same thing. This is very valuable from a clinical point of view when physicians discuss. It's very valuable from a scientific point of view when we exchange on different research projects that we have. But we also have to understand that just because we put this definition, number one, it's not cast in stone. It can be discussed and should be discussed. And the second point, I think is also important. This doesn't mean that whatever the definition is, there is a clinical consequence, or the extent of the consequence is the same. So we need to research on the consequence of our definitions if they are at the end of a practical value, and if we see that we define patients who need a certain treatment or a certain attention or something like that. So having a definition, great. Discussing it, even greater, and then researching with these different tools is our task as physicians.
Thomas, could I just make a very quick comment to support that? You know, where we're really learning a lot of lessons is with COVID. So myocardial injury in COVID is incredibly common, and depending on how you define it with a troponin rise. And what we're realizing is there are about 5 to 10 different causes of myocardial injury, of which type 1 and type 2, type 1, type 2 MI are only 2 of the sort of 8 pathophysiological mechanisms. So it's really quite instructive.
Shireesh?
Yeah, I think I agree with Dr. Gersh. I think we have to have a precise definition of peri-procedural MI, whether it is peri-PCI or peri-CABG, because not only has got clinical implication, it also has got implications on the outcomes of the study, and that can change. So we have to have a very perfect definition of peri-PCI.
No, I think this is very important. You can't jump from a SCI definition to a universal definition at your convenience. Ajit, final comments from you, Ajit, and then we go back to Dr.
I think the topic has been well covered, and I think the importance of myocardial injury has been stressed. And I think a common definition is important when we define trials before we jump into the trials and dissect it after that. So I think it's important that we make some universal definitions universal. So with that, maybe we can go on to the next lecture by Dr. Gersh.
Dr. Gersh requires, I think no introduction at all. I think he's a giant in the field of cardiology. And all of us who've looked at time versus muscle, the graph that I think virtually all of us put up in our talks on STEMI, that came from Gersh's landmark paper. So you're going to talk on pharmaco-invasive strategy, which we talk about as something that we use in low and middle income countries, but maybe there is a place even in the developed countries. Dr. Gersh.
This is Bernard Gersh. I'm delighted to be part of this STEMI India meeting again, as I have been involved in the previous few years. And my topic for the first talk is current status of reperfusion therapy in the community. One size does not fit all. And really, I'm going to talk about the pharmaco-invasive strategy, which applies to most parts of the world. Now, the relationship between mortality reduction and the extent of salvage, many of you have seen this, a curve from a paper written in 2005. This is a hypothetical construct. It's not based on hard data, although subsequent data tend to reinforce the hypothesis. The black line is the reduction in mortality. The area on the horizontal axis is the hours, the duration of ischemia before reperfusion. The area under the curve in pink is the extent of salvage, and the pink starts to fade as you go out in time because less myocardium is salvaged. And the point I'd really like to make is, or 2 points. One is that this is not a constant relationship. It can depend upon a whole number of modifying factors that can shift this curve to the left or to the right. What is important are to understand the treatment objectives. At this part of the curve here, time to treatment is critical, and delay is muscle. And really, it's a very narrow window of opportunity. Once we get out here to the flat part of the curve, from here onwards, really what is important is not so much time, but opening the infarct-related artery. And in this setting, thrombolysis will always be inferior to PCI because the clots become more resistant to thrombolysis. So I'm not saying that it's not important to reperfuse or do primary PCI at this point in the curve. I'm just saying time is not that important. Whether you open the artery here or here or here is not going to make a great deal of difference, whereas it will on this part of the curve. Primary PCI for all is a worthy goal, sure. But for the majority of the world, the pharmaco-invasive strategy is the only feasible and logistical option. And realistic goals are to administer reperfusion therapy to as many and as quickly as possible. It's not, obviously, we all agree that primary PCI, all things are equal. Primary PCI is better than thrombolysis. But what's important is to give reperfusion therapy to as many and as quickly as possible. We know what to do in 2020. We know when to give lytics. We know about primary PCI. And we know a lot and a great deal about logistics and transport. But what we have to understand are the physical constraints. We know what to do, but geography, distance, and weather may have a huge impact on what we are able to do. And then the coordination of services. This is another important factor. How does the patient present? Do they come through 911? Do they come straight to the hospital? Do they go to an outlying hospital? And these are important determinants. And the coordination of services varies by institution, region, and the allocation and the availability of resources. And obviously, this is also country dependent. Now, in the United States, the pre-hospital time period to a PCI hospital is less than 60 minutes in most of the country, most centers in the country. And if you look at the big urban centers on the West Coast, Los Angeles, San Diego, San Francisco, the densely populated East Coast cities, areas like Chicago, southern Florida around Miami, there's no shortage of cath labs, and most people live very close to a PCI hospital. But the United States is a big country. And in these areas shown in the tan color, patients are greater than 60 minutes from a PCI hospital, and the driving time is significant. Brahmaji Nalamothu did this analysis that 79% of patients in the United States are less than 60 minutes driving from a PCI hospital, or 60 minutes from a PCI hospital. But if you look at those who come to non-PCI hospitals, the driving time from a non-PCI hospital to a PCI hospital is less than 30 minutes and 74%. But you've got to look at it the other way. In 25% of patients, that's a quarter, the driving time is much longer. And this may be where, even in the United States, we need a pharmaco-invasive strategy never mind other parts of the world where their distances are great. So setting up a network is a class 1 indication from the guidelines. We need to know what we're doing, and they need to be evidence-based, they need to be well articulated. And this is the goal. It's not to get more patients than the other hospital down the road. The goal is to enhance the speed and delivery of reperfusion therapy to all eligible patients, not just one health system versus another. And they must need to be clear and well articulated and simple. They must adjust to local conditions, clearly define roles, universal buy-in, simple to follow 24/7. Let me give you an example. In Olmsted County, Minnesota, which is where the Mayo Clinic is located, we have 3 helicopters of fixed wing and ground transport. Now, we do offer reperfusion therapy 24 hours a day and 7 days a week. But for 60 days during the year, our helicopter may be grounded for part of the day because of tornadoes or severe winter blizzards. So our protocol has to adjust for that. It has to be flexible and adjust to local conditions. You can't fly the helicopter 24/7, at least not in our climate. Continuous audit, adapting new knowledge. If you don't measure it, you can't analyze how well you do. So you have to continuously audit your results. And I think that I'll pay tribute again, Dr. Tom Alexander, and what he's done is very impressive in terms of developing a system that works for Southern India. Now, our community hospitals at Mayo Clinic, we have about 30 community hospitals within 150 miles of Mayo, Rochester, or St. Mary's Hospital. And this is the protocol we've developed. If you have a relatively short duration of symptoms and you're on that steep part of the curve and you need to be transported to the cath lab, we embark upon the pharmaco-invasive therapy using TNK. We then transport the patient either for rescue PCI, or if they're stable, we wait 3-4 hours and then do a routine angiogram. That's the pharmaco-invasive strategy. Whether we use a ground ambulance or a helicopter depends on weather. The watchful waiting approach, leaving them at the community hospital and transferring them if they get symptoms, has worked in some parts of the world, but we don't do it. If they're on the flat part of the curve, when they contact us, they've already had at least 2 hours of symptoms. Time is not as critical. We then just transport them straight to the cath lab for primary PCI, and we do not give the pharmaco-invasive strategy. So you might ask why. Well, there is a risk to thrombolytics. It's relatively small, but there is a risk of intracranial hemorrhage and bleeding. And in these patients, we don't think the added benefit of trying to get earlier reperfusion justifies the risk, because they're already on the flat part of the curve, and the older the clot, the more resistant it is probably to fibrinolysis. We do not facilitate with fibrinolytics. So the pharmaco-invasive strategy the pharmaco-invasive strategy in a regional network, our results are shown here. Published in AJC, 1,700 patients, 2004 to 2012. Median follow-up is 3.9, 4.4 years. And if you look at mortality and all-cause mortality and 30-day mortality, and this is 5-year mortality, it looks as though the pharmaco-invasive group actually do better than those who had primary PCI. And I need to just emphasize again, in patients that present to St. Mary's Hospital, Rochester, where we have a cath lab, they all have primary PCI. All that I've shown you in regard to the network is how we deal with patients who present in our outlying hospitals. Now, it looks like the mortality is lower with pharmaco-invasive, but remember, this is not a trial, it's a registry, and when we did a multivariate analysis, these statistically significant differences fell away, and the conclusion that we could draw was that in patients who present to our network, of community hospitals and are treated according to our protocol, the results are not significantly different from those who pitch up at our front door and undergo primary PCI. And so I think this is a study, it's not a trial, but a study that shows the benefits of a reperfusion network and the pharmacoinvasive strategy. A good deal of work on this has been done in Alberta, Canada, by Dr. Rob Welch and Paul Armstrong. These are their registry results. They have very large distances in northern Alberta and severe weather. If you compare the pharmacoinvasive strategy in 55% of patients, primary PCI did significantly better, but slightly better, significant but modestly better in terms of ST resolution. But if you look at the endpoint of all-cause death, heart failure, shock, and recurrent MI, the pharmacoinvasive strategy was significantly better, and major bleeding was no different in the two groups. This is from the STEAM trial. This is a subset analysis by Dr. Gershlik. This was a trial of the pharmacoinvasive strategy. And what is shown here is the PCI-related delay. That is the delay incurred when you first see a patient and you decide to transfer them for primary PCI. How long does it take before they get reperfused? So you see a patient out in the field and you could give them a fibrinolytic, but you decide you're sending them to the cath lab. How much PCI-related delay is there in transporting the patient to the cath lab? And this is the effect on 30-day death, heart failure, shock, MI. You see in patients treated very early after the onset of symptoms. When I say treated, transferred for primary PCI, there's no penalty to be paid. But once you start to get out to a 90-minute or longer delay, so you're seeing a patient in the field, you want to do primary PCI, and you send them by ambulance to the cath lab. Once it gets over 90, 100 minutes, there seems to be a trend very much in favor of the pharmacoinvasive strategy. What do we do in the United States? So this is a large registry of patients. This is the guideline-directed times before reperfusion, and the guidelines recommend 120 minutes. 90 minutes is ideal. So these are patients who presented to an outside hospital and were transferred for primary PCI. If the drive time was less than 30 minutes, 67% of them had a door-to-balloon time of less than 120 minutes, which is consistent with the guidelines, and very few got fibrinolysis. I think that that's okay, although I would say a third of them did not fall within the guidelines. Maybe they should have had fibrinolysis. These are people who were again seen at this point in time. You can see here, but somewhere within the 120-minute period. But the drive time was longer, 31 to 45, 46 to 60 minutes. Now, only half of these patients transferred for primary PCI had a door-to-balloon time within less than 120 minutes, and only 20 to 30% had fibrinolytics. And maybe more of these patients should have been treated with the pharmacoinvasive strategy so as to ensure earlier reperfusion within the guidelines. And in those who presented within 120 minutes, probably if you look at the blue, they're presenting within about 80 minutes. The drive time in this group was greater than 1 hour, and only 29.6% had reperfusion within the guidelines of 120 minutes, and only a half of them had fibrinolytics. So I would argue that in many of these patients, the pharmacoinvasive strategy would have benefited them even within the United States. And the median drive time, the median, was almost an hour. So we're underutilizing it. One size does not fit all. You have to work out what's best for you. And you've done this so well in demonstrating this in Dr. Alexander's series in Chennai. Further improvements are going to focus on outside the PCI hospital. We know what to do once they come into a cath lab PCI capable hospital. The biggest, one of the largest delays is transfer times, door in, door out. And we need to develop systems and protocols and communication. Improvements in door-to-balloon times in the PCI center itself have been substantial, but they haven't altered mortality. I think they're a surrogate for overall quality of care. If you have a short door-to-balloon time, you're probably doing other things well. And this is one of the most difficult things to do, and that is persuade patients to present earlier and not wait for 1 or 2 hours at home. So far, before presenting or before calling an ambulance. So far, we haven't been very successful in modifying this at all. This is the area for the greatest gain, and that is transfer time. Shorten the transfer times. Obviously, in people who present to a PCI-capable hospital, what you need to do is just keep your door-to-balloon times as short as possible. So key messages. Timely transfer for primary PCI is our biggest challenge. More than 50% of patients have a door-to-device time of greater than 120 minutes in the United States. That is outside the guidelines. EMS this applies to the US. If you're in a city where you've got a primary PCI-capable hospital next to a non-PCI-capable hospital, for the ambulance to take the patient to the non-PCI center is, I think, a system failure. The major component of delay is in transfer times. The major delay in transfer times is in obtaining transportation. Once you've got them into the referral hospital, get them out quickly, and you need to have a system that has transportation available right on the site. I think if the transport time is greater than 45 minutes, a general strategy should be lytics followed by immediate transfer. And why do I say general? Well, if it's someone aged 85 with hypertension, a frail elderly person, the risk of intracranial hemorrhage is substantial. And so it's not one size for everybody. But in general, if you have to wait for 45 minutes for transfer, you should use the pharmaco-invasive. And then even then, you need to have a plan for the timely transport of lytic ineligible patients as well. So community approaches to STEMI in 2019 and now 2020, it's not only the nature of the therapy, but the efficacy of its delivery. And so what you do in a PCI-capable hospital may not be what you do if the patient needs to be transferred and presents to a non-PCI-capable hospital. We all do primary PCI. We can all give lytics. What is important is the efficacy of our delivery to as many eligible patients and as quickly as possible. Thank you for your attention.
Of symptoms with tenecteplase and follow it up with an angioplasty within the next 24 hours, then the results are as good as primary angioplasty. So if we have our systems in place in India, we can certainly go ahead with that. And I think pharmaco-invasive will be the way to go for majority of Indians with similar results to primary angioplasty.
Can I ask Rajesh, he's with us, and Dr. Wonder, any comments on these? Yeah. Dr. Wonder?
Yeah. I think what Dr. Gersh showed beautifully is different places, the challenges are different. Like the weather issue, he said, is such a big issue in his area of working. And similarly, the place where we work, Dr. Mulasari knows, actually, because the National Health Service system has not yet penetrated so much in our state. And so consenting with the patient becomes a significant issue, because when you offer for patients 3 kinds of therapies with 2 thrombolytics pricing so differently and primary PCI, sometimes very valuable time gets wasted even in institutions where primary PCIs are feasible. So different places have different challenges, and we have to improvise according to our circumstances to reduce these periods as best as possible.
One of the most interesting, in that respect, one of the most interesting papers I read was about 2 years ago from Shanghai, in Shanghai, China. They have no shortage of cath labs, but they have a shortage of doctors. And in this particular study, what they did was they flew the interventionists to the cath labs rather than the other way around. And that worked for them. The results were really good. So, apparently in Shanghai, there's a cath lab on every street corner, but not enough doctors to staff them all the time. So it was the physicians that went in the helicopter, not the patients.
I think also the FASTMI registry was a very important registry. It showed that even in France that, delays occur and you may have the best systems together, but, you can get caught in traffic. And really, if you delay your time, then a pharmacoinvasive strategy is superior to primary PCI, and I think the loss to myocardium is even lesser with a pharmacoinvasive therapy. So I think it's and especially the COVID era has reinvented the thrombolytic, and in a way, it's got us back to this scenario that your systems may not be only money related; it may be a period of time like a COVID-19, which completely disrupted your system. So I think this is an important takeaway, Dr. Gersh.
Well, when I started talking about the pharmaco-invasive strategy, years ago, people sort of almost ridiculed us and said, "What's wrong with the Mayo Clinic? Why don't you do primary PCI?" And I remember presenting at a meeting in a small European country, and someone got up and said, "I think your whole system is completely wrong." And I said, "Wait a minute, I can walk across your country in about half an hour if I'm in a hurry. The weather's the same every day, it just rains softly. I mean, have you any idea what the area in which I live and work looks like?" And we have these distances and geographical barriers and so on. And even now, I think the one paper that I showed, the one study, it's quite striking how few people, relatively, are achieving guideline-based therapy unless they're in a city where there is primary PCI. So for so much of the states, and I live most of my time in Wyoming, we have huge distances and big mountains that you've got to cross. So the pharmaco-invasive strategy is the only strategy that will work for the majority of people who do not live in close proximity to a PCI-capable hospital.
Dr. Gersh, what is the percentage of patients undergoing pharmacoinvasive in the US? In India, it is around 85 to 90%.
I think I'm guessing in our system, it was about 35%. And that's, we have 3 helicopters, a fixed wing. We keep 2 helicopters out in the field. 1 is based at our hospital. That's about 35%. I'm actually guessing, but if you wanted to get a better idea, if you look up the data from the race registry, now the race registry is from North Carolina. Christopher Granger is very involved with that, and Dr. Jamie Jollis, Jollis. Their papers came out about 3 to 4 years ago, and they tell you exactly what has happened in the state of North Carolina. And that may be a slightly more accurate idea of how many get pharmaco-invasive. What bothers me, or some of the data that I showed, were people who should have got it didn't get it. I think really there was a period where it was considered the only way to treat someone was with primary PCI, and everybody else was being on the wrong foot. Well, I don't think that stood the test of time. I mean, I think what is really important is how many people get treated within the guidelines, and you have to modify your system accordingly. We're very comfortable with ours, but we've looked at our results. I just can't give you an overall figure other than I think it was 35 or 40% in our own series.
Chris, last comment from Europe.
Thank you very much, Ajit. No, I couldn't agree more with Dr. Gersh. And I grew up with the knowledge that primary PCI is the only therapy, because in Germany we're only doing that. And I learned to all of you how useful the pharmaco-invasive approach is. And I have to say, I was really interested what Dr. Gersh just presented, especially the slide about the additional delay coming through PCI. This is something we realize also in Germany, in many countries, and I sometimes think, that having so many cath labs in Germany is sometimes not useful, because the patients are divided so much that the volume goes down, and then the teams are not really trained. So maybe even, in Germany, we could either concentrate a little bit more the cases, or we could think about a pharmaco-invasive approach and really measuring the delays instead of always saying that the situation here is ideal. So thank you very much for this comment, and thank you all for this learning for me over the last years.
Thank you very much, and I'd like to thank all the speakers. They've done a fabulous job. Dr. Gersh, Dr.Jagat, Narula, Christopher Naber, Dr. Wanda, and it was a very, very nice session. So thank you very much, and we'll see you for the next few sessions soon. So thank you very much for spending your time for this meeting and spending your valuable time with us live for the question and answers. Thank you.
Please, Shruti.
So Shruti, can you get the slide
of death in women? In fact, women have more than 1 million STEMIs per year. It is well documented that women with STEMI receive suboptimal care and have worse outcomes than men. Here's some examples from this standpoint. When you look at guideline-directed medical therapy in women, you see a lower utilization of aspirin within 24 hours, 91% versus 93% in men, and a lower utilization of beta blockers, 85% in women compared to 87% in men. You also see clearly slower door-to-balloon time performance in women, and this has continued despite the fact that overall door-to-balloon time in the United States and in other countries has improved substantially. And there continues to be a gap in time to reperfusion for women. Because of this, you ultimately derive worse STEMI outcomes in women with a higher rate of stroke, heart failure, and major bleeding. Ultimately, this leads to what was found in a meta-analysis that women have a 48% increased risk of in-hospital death in a meta-analysis of over 68,000 patients from 35 different studies. This has led to an international call to action. The European Society of Cardiology's 2000 STEMI guidelines show that women tend to receive evidence-based treatments less frequently than men, and the American Heart Association statement on acute myocardial infarction in women notes that closing knowledge gaps on acute myocardial infarction clinical presentation and treatments for women are a public health priority. So therefore, because of this, strategies to improve STEMI care and outcomes in women are clearly needed. So the objective of our work here at the Cleveland Clinic was to study the care and outcomes of women with STEMI before and after implementation of a comprehensive STEMI protocol. So this is a registry that we put together of nearly a substantial number of patients from 2011 to 2016. We included all of our patients. And in July of 2014, we implemented what we describe as a comprehensive four-step STEMI protocol. The control group here on the left, before the implementation of this protocol, was a joint decision to activate the cath lab between the emergency department and cardiology. There wasn't a standardized approach to initial triage and management, and the patient was transferred to the cath lab when it was ready, and vascular access was operator dependent. With the comprehensive four-step STEMI protocol, we standardized the emergency department physician catheterization activation. We created a STEMI safe handoff checklist. Patients were immediately transferred to an immediately available catheterization lab, and we used a radial-first approach to primary PCI. Our outcomes in the study included the utilization of guideline-directed medical therapy. We defined this as aspirin and a P2Y12 inhibitor and anticoagulation, both prior to arterial sheath placement and prior to completion of PCI. We also measured door-to-balloon time, and we looked at clinical outcomes such as in-hospital adverse events and 30-day mortality. Here are the results of this study. The control group consisted of 723 patients, of which about one-third were women, and the comprehensive four-step STEMI protocol had 549 patients, which again, about one-third of them were women. If you look at guideline-directed medical therapy prior to sheath placement, we saw a substantial improvement in the control group and protocol group, going from 74% to 83% during the comprehensive STEMI protocol. Radial access for primary PCI also increased substantially, going from 18% to 67% with the comprehensive STEMI protocol. What we saw in door-to-balloon time was also a substantial reduction in the average door-to-balloon time from 121 minutes down to 91 minutes. And particularly, we noted a substantial decrease in the variability of door-to-balloon time. If you look here on this graph, the difference between the minimum and maximum door-to-balloon time substantially decreased. When you looked at the population of patients overall, women were substantially older with higher BMI and a higher rate of cardiac risk factors, including hypertension, hyperlipidemia, diabetes. They also had increased risk of prior cerebrovascular disease and chronic lung disease. Therefore, women clearly had a higher risk factor burden compared to men. From a procedural standpoint, overall presentation location and the prevalence of shock and cardiac arrest were similar. Women had more likely to have a salvage PCI status and required intra-aortic balloon pump placement, but had less fluoroscopy and contrast utilization. In the control group, as noted in many national and international registries, what we noted were that the women had lower use of guideline-directed medical therapy, both prior to arterial sheath placement and prior to completion of PCI. This indicates that this was similar to what had been seen in many other registries in the country and across the world. Similarly, in the control group and door-to-balloon time, what we saw was a substantial greater door-to-balloon time overall for primary emergency department patients, for inter-hospital transfer patients, and for in-hospital patients. So no matter how women presented in terms of location, their door-to-balloon time was slower than men. When you look at it baseline, what we saw that baseline in-hospital adverse outcomes showed a substantial increase of stroke, vascular complications, bleeding, transfusion, and death, similar to other studies nationally and internationally. Ultimately, in the control group, 30-day mortality in men was 4.6%, and in women it was 10%. A substantial difference, highlighting the baseline higher risk profile for women and less appropriate care, leading to higher mortality. So in our control group, similar to other studies nationally and internationally, women with ST elevation myocardial infarction were less likely to receive guideline-directed medical therapy, had longer door-to-balloon times, more in-hospital adverse events, and higher 30-day mortality. Once we implemented the comprehensive four-step STEMI protocol, we saw a near equalization of guideline-directed medical therapy, as seen here, showing a similar amount of guideline-directed medical therapy prior to arterial sheath placement and prior to completion of PCI. Prior to completion of PCI, men were at 97% and women were at 98%. Door-to-balloon time differences evaporated, and there was no difference overall, primary emergency department, transfer patients, and in hospital in terms of door-to-balloon time between men and women. And very impressively, these improvement in care led to substantial improvements in in-hospital adverse events. And we saw no statistical difference between men and women when it came to shock, stroke, dialysis, vascular complications, bleeding, transfusion, and death. Women, and if you look at women in the control group compared to the protocol group, you saw substantial reductions in stroke, and you saw a 50% reduction in mortality. And when you look at 30-day mortality here, you see a substantial improvement from men from 3.3%, and now women were only 6.5%, and this difference was no longer statistically significant. When you look at the control group of women, you saw a nearly 40% reduction in mortality for women, although this was not statistically significant due to the smaller sample size. The limitations of this study is that it's a single center experience. It has a historical control group. We're underpowered for mortality. All patients required revascularization. In summary, a comprehensive protocol improved guideline-directed medical therapy, door-to-balloon time, in-hospital adverse events, and 30-day mortality. With the comprehensive STEMI protocol, the magnitude of improvement was greater for women compared to men, and it ultimately reduced sex disparities. This was published in JACC as the four-step protocol for disparities in STEMI care and outcomes in women. One of the big questions is whether this can be sustained, and we now are analyzing 5-year data which actually shows strengthening of findings, and this has been submitted for publication. So in conclusion, systems-based solutions to minimize STEMI care variability offer the potential to provide equal care of men and women, resolving the long-standing gap in STEMI care and outcomes. Thank you very much for the opportunity to speak to you today on this important topic.
welcome what Umesh you presented in the control group. And I think if we work towards a system, we'll get that right. So can I have some comments from Shireesh, Dr. Gersh and Rajesh before I ask Umesh to close the summarize?
I have a question and a comment for Dr. Umesh. If bleeding is the main issue, which is differentiating outcomes in men and women, then have you considered any female-specific antithrombotic regimen so as to reduce bleeding? Dr.
I think that we think bleeding is one of the elements that is part of this, but we don't think it's all of that with regards to bleeding. One of the things we find out, even for example, when you adopt a radial first strategy, there still is a lot of femoral access needed often for support devices or temporary pacemaker. So we don't see an elimination of bleeding, we do see a reduction from that standpoint. And that reduction is more prominent in women than men. We haven't adopted anything specific with regards to any changes in antithrombotic or other treatment for women, although I think that's a good question in the sense that women in general with their smaller size may be more sensitive, and there's been some data in non-STEMIs that sort of show some dosing issues, but we haven't adopted anything specific for that.
Yeah, and I can understand this bleeding as well as the high risk factor load in women, but it really beats me to understand why there is suboptimal guideline medication for the females and also the delay for the females. What could be the reasons for that? Delay in presentation and suboptimal therapy.
I think we think that
what could be the reason?
Presentation tends to be a little bit more complex in the sense that the symptom presentation may be a little bit different in terms of classic chest pain, and they often present with, a more complex. We talked about there was a higher risk of salvage PCI, and so their presentation when they do show up is often sicker as far as that. And so the issue is you have to have a system that is robust, that no matter how the patient presents, it can handle them very aggressively, quickly, and rapidly.
I think there may be a factor too that a man, husband gets chest pain, says to his wife, call 911, get me straight to hospital. And maybe there's an element of denial. Maybe it's also, well, look, I've still got to get the children to bed. I need to cook your dinner, and they present later. And there may be a psychosocial factor we don't really understand, but they do. And one of the things that's really been brought home to me is a paper currently under review put together by Tony Gershlik, who many of you know. He's been to India several times. But Tony put together a very large registry of hospitals, mainly in the UK, but in 4 other continents, and looked at the results of STEMI and non-STEMI in the COVID era and compared them with a large UK registry from the British Cardiovascular Intervention Society from the year before COVID. And what is absolutely striking to me, it hasn't been published yet, it's still under review, but it's this. The ischemia to no door time just went way out. It probably trebled. And this is people are reluctant to go to hospital in the COVID era. And the rate of cardiogenic shock went from 4% to 20%. And the mortality of myocardial infarction, STEMI, went from somewhere like 3% up to about 18%. So if ever I've seen an example of delay to therapy and its impact on results, it's this artificial trial or experiment of the COVID era. And women do present later.
Presentation on multivessel disease in STEMI, current approach.
I'm going to have to leave the meeting. I'm scheduled to give a virtual talk in New York And I will be back tomorrow.
Thank you,
So
Dr.
thank you very much, everybody. But,
Many congratulations to Dr. Thomas Alexander, Dr. Ajit Mulasari, and Dr. Shireesh Sathe for organizing this virtual conference on multivessel disease, or basically STEMI, where I'll be probably interacting on multivessel disease in STEMI. And it's a privilege to be there. Compliments to all the organizers. The extent of the problem is enormous, actually. Approximately 50% of STEMI patients at primary percutaneous coronary interventions have multivessel disease. And initially, it used to be a big dilemma as to, how to proceed with, whether to tackle the IRA or the non-IRA at the same time or stage it. These questions were not answered, and the fog was quite dense. Over years, the fog has been less dense now due to lots of articles which have been published, randomized actually, whether what is the approach to be taken. This is what we are actually going to discuss in this topic of mine, which is multivessel disease in STEMI. Now, as per the data, ACC and AHA until recently advised against routine PCI to non-culprit vessel at the time of primary PCI. It was a no-no initially, but as years passed by, as we mentioned earlier, several randomized trials which made us believe that multivessel PCI is possible during acute myocardial infarction. And thus recommendations have been upgraded to class 2B as per ACC-AHA and to class 2A as per ESC for considering PPCI for non-infarct in selected patients with STEMI and multivessel disease, either at the time of primary PCI or as a blind procedure. Now, if you look at the trials, it could be, as staged and as at the time of index procedure, and then we have special subsets in the form of cardiac shock and multivessel disease and STEMI with CTO of non-IRA. So if you look at the trials, we started spanning the trials from 2013 on to 2017, and then going on to 2019 as latest as that. And then we will further discuss 2017 and 2016 trials and special subsets. So this is a nutshell of the trials which actually have been published. And if you look at the first trial, the initial ones in 2013, multivessel PCI at the time of PAMI, primary trial, where after primary PCI, randomization took place to immediate preventive PCI and no further PCI. This was actually around 500 patients in 5 centers in a single blind randomized study. And the trial clearly showed that preventive PCI is a better option than ischemia guided intervention. However, it did not answer, there was a fog, there was confusion whether it is to be done immediately or a staged one. But the MACE, that is a combined rate of cardiac death, non-fatal myocardial infarction, or refractory angina, was reduced to as high as 60 to 65%, as can be seen in this log diagram, where you can see the curves separating gloriously over 36 months period, and clearly the patients without primary outcomes, and preventive PCI was clearly better than the IRA-only strategy. We have the CVL, that's a culprit trial in 2015. Where the patients were randomized prior to primary PCI the PCI to known RA, preferably at the index and procedure, or at least at the index admission, or no further PCI. And this included around 300 patients from 7 centers in a multi-center randomized open label trial. And the culprit trial clearly demonstrated again that complete revascularization at the index admission resulted in a significantly lower MACE rate at 12 months, as can be seen, in the log diagram over here, the curve separating over 12 months period, or the reduction in MACE rates and complete revascularization and significant reduction in MACE. So the conclusion with the culprit derived was that among STEMI patients, complete revasc appears beneficial at reducing major cardiac events, and benefit was basically seen due to reduction in repeat revascularization. So death, myocardial infarction, heart failure, or repeat revascularization, as can be seen, is clearly a more than 10% reduction. Then we had the compare acute study in 2017, where the primary PCI were randomized to FFR-guided PCI to non-infarct-related arteries and non-further intervention. Now this basically was a prospective multi-center randomized trial of around 900 patients. And here, any patient on luminography who had contained stenosis of more than 50% was subjected to FFR. But the charm of the study was that it didn't indulge in doing angioplasty in unnecessarily eyeball case, which was having a lot of confusion. So the primary endpoint of major adverse cardiac and cerebrovascular events angioplasty to no further intervention clearly suggested that FFR-guided complete revascularization prior to hospital discharge is superior to culprit vessel only PCI. The primary outcome in the form of major cardiovascular events for FFR-guided only PCI was 13 versus 22. So clearly statistically significant, and the benefit was basically driven by significant reduction in ischemia-driven revascularization of 5 to 17%, as can be seen in this log diagram, where the which has been reduced in complete revascularization to infarct-related artery only. The latest trial being the complete trial, where primary PCI was randomized to complete revasc to stage PCI, either the same index or intervention. And this had 4041 patients, quite a large number, in 140 centers all over the world, in 37 countries. Now, what did this trial show? That complete revascularization was superior in reducing the risk of cardiovascular death or myocardial infarction or ischemia-driven revascularization. The limitations, of course, all the trials had limitations. In this particular trial, they did include non-culprit PCI that was performed during the index period. And no patients are stable patients. So, as you can see in the cumulative incidence and the cumulative incidence in both the ways, the second bar showing complete revascularization, in addition to the mortality reduction, the curves completely separating with p-value being significant in the or myocardial infarction or ischemia-driven revascularization. Now we have special subsets of tackling STEMI, especially if the patient has myocardial infarction and the other vessels which are involved, be it the RCA or the CERC or the LAD, either of them in the form of a CTO. Now, basically, whether to do it or not at that point in time was this study which was performed, and clearly, this had a prospective multicenter international randomized trial of around 300 patients. The basic thing was nothing much turned out to be except for the fact that if the sub-analysis was performed in this EXPLORE trial, which said that only patients who had a LAD affection, the translation was in the form of increment in the left ventricular ejection fraction. And besides that, there was no difference in the mortality. And it can be seen clearly as far as the limitations are concerned that the patients with high-risk characteristics in the form of ventricular arrhythmias or shock and out of hospitalization were not included, and the study was not blinded. As you can see, there was no improvement in the left ventricular ejection fraction overall, except if you tackle CTO and LAD section. So that was a subgroup analysis which was performed. So clearly nothing much out of this article, however, some sort of array there. The second subset is STEMI with cardiac shock and multivessel disease. Now, this was a culprit trial in 2017. Cardiac shock presents a special enigmatic subset with up to 80% of the patients with STEMI and cardiac shock who have multivessel disease. Now, to tackle all the vessels at the same index procedural time or maybe probably shortly before discharge probably might pose a bit of a problem for a simple reason that induction of further ischemia, volume overload, or renal impairment due to increased contrast volume might really add to determinant of the case. This was basically a multi-center randomized trial which included around 700 patients, at 83 centers. And the results were that at 30 days, the rate of composite primary endpoint of death or renal replacement therapy was significantly lower in culprit lesion only. So basically, they said that in cardiac shock, just restricted to the artery which is actually posed as a villain and not to, indulge in other extrapolations of, tackling the other arteries. All-cause mortality was significantly lower in culprit lesion only as PCI group. And the findings were basically in contrast to stable patients. However, at 1 year, it showed no mortality difference between the two groups. So this was a clear sort of a message for us. You can see the logs separating in all the three cases. The basic being that that you have a reduction in the endpoint of death or renal replacement therapy at 30 days, at 1 month period. After 1 year, there's not much difference really, as can be seen in the log of all the three subsets. Now, what is the timing of non-IRA intervention? Basically, it is imperative that when you have a case of STEMI, and if you have multivessel disease, it all depends upon what is the comorbid state, what is the stability or instability of the patient, what is the LV of the patient. We have to basically look at all the considerations, as can be seen in the algorithm, which will give us a clear idea. Basically, I think it's a neat algorithm where if you have hemodynamic instability or ongoing ischemia or uncertain culprit lesion or unstable appearing lesion, if they are there, then just proceed with multivessel PCI at the time of primary PCI. Or if you have got an uncomplicated subset or a simple PCI of a non-culprit lesion or absence of any known chronic kidney disease, just go ahead with it. If you don't have any of these subsets, then defer the non-culprit PCI and perform it, if you have a non-culprit artery supply, a larger area of myocardium, or if there's absence of chronic kidney injury, or absence of multiple comorbidities, then stage them, maybe after, within 45 days or so. And if these are not the answers, then just do the ischemia-guided approach to the non-culprit lesion. I thought this was a fairly nifty sort of an algorithm. So what do we have finally as far as the guidelines are concerned? You have ESC guidelines for the middle block non-IRA PCI, actually culprit shock trial followed the ESC guidelines in 2017. So it says that routine revascularization of non-IRA lesions should be considered in STEMI patients with multiple vessel disease before hospital discharge. It's a class 2 AA. And the ACC AHA in 2015 focused that PCI of a non-infarct artery may be considered in selected patients with STEMI and multivessel disease who are hemodynamically stable either at the time of primary PCI or as a planned state procedure. So what is the take-home message we have? We have a take-home message that if you have a STEMI and if you are multivessel disease, tackle the culprit artery and the subset which is strongly in favor of the patient, that means no kidney injury or the stable subset, reasonably okay ejection fraction, and the patient does not have much of comorbidities, you probably can venture into doing it at that point in time or during the index admission. If you have all sorts of complex events which are there, the LV is low, or you've got creatinine, which is not very conducive to the patient, I think one should just wait, maybe do it a couple of weeks later. And that is what probably is a message very clearly given for multivessel subsets in STEMI. I end my talk and compliments to the organizers once again. Thank you for your attention.
Rajesh, for a nice presentation which clearly summarizes the trials for multivessel disease and PCI. So maybe I can ask a few comments from my co-chairman Shireesh Sathe. Shireesh?
Yeah. I think we need to have new guidelines on the basis of complete trial, because it's a big trial, 4,000 patients, and it's powered enough to prove efficacy compared to the previous PRAMI or Culprit or even Danami trials, which had only a few hundreds of patients. And we have now, I think, clear-cut idea in how to go ahead with primary PCI and multivessel disease. But I have a question for the all panelists really. What about CABG? What is the approach? Because if you have a culprit lesion which is doable and the other lesions which actually need bypass, then what should be the strategy? What is the approach?
Well, my personal perspective, this is a very important question, and this happens very often in the cath lab, at least in our scenarios, that we do the inferior RCA, and then you have a complex left main LAD and say circ, and then you decide what to do. So normally the surgeons are reluctant to go in with a STEMI patient very quickly, and they normally would say about minimum of 3 weeks to a maximum of 4 weeks is what our surgeons do, unless patients are hemodynamically unstable. That means that even after doing the right, they have some critical left main or LAD lesion which makes them ischemic during the hospital stay or something like that, they would go in. But the complexity there is about antiplatelet therapy, and that's where problems occur. And, if you use the longer-acting antiplatelet drugs, which cannot be reversed, then that becomes an issue, especially the P2Y12s, because aspirin is not an issue for most of our surgeons. It's only the P2Y12 or the 2B3A receptors that make them a little cagey. But I think this is the format that we do. If it's a stable MI, we've started it and you're taking surgeries 3 to 4 weeks. If it is unstable, then we do it earlier, but we withdraw the antiplatelet P2Y12 inhibitor quickly. And even when you do the angiogram, you make a decision then what to do in these patients, which sort of treatment to do, how to treat it. We've had even patients having a simple balloon, say as for the right, without even putting a stent, and then go for surgery for the other vessels, because that makes it very simple, so you don't have issues with stent closure when you have the antiplatelet second one withdrawn. Maybe Umesh and Ranga?
Yeah. I think Rajesh kept repeatedly emphasizing on the problem of renal function. I think that's what really decides many of our patients' short-term issues on terms of what happens to these patients. I think renal dysfunction, and we use a lot of contrast and do multivessel angioplasty. I think they'll end up in much more problems than when we do a culprit vessel and come out, especially with renal dysfunction. And specifically to Ajit, to what you said, what would you do if you had an atrial infarct and you did an LAD angioplasty and the remaining vessels were whatever the data has shown that again CABG, if it's a non-LAD disease, then it doesn't really make this. Would you still do them? I think, would you do the multivessel? If you've done a circumflex on an RCA, then you have a complex left main, then sending them for CABG is a different question. But I think if you've done an LAD and then circumflex, and I think probably either, if you think there's a problem, if everything is okay, pre-discharge, do the multivessel angioplasty and send them away.
I think in non-LAD lesions, we really don't chase surgery at all. Non-left main and LAD lesions. So I think it's either medical treatment or PCI for those vessels. That's how we do it. Umesh?
Thank you, Rajesh, for an excellent presentation. I think this highlights just a dramatic change in the guidelines. We think guidelines are sort of written in stone, but if you go back almost a decade, this was so against it that this was actually labeled as a low-value care, and there was actually initiatives in the U.S. to stop people from doing any type of non-infarct-related PCI or revascularization because it was thought to be of such low value. So I think you really highlighted how that has completely changed in terms of the literature. I think regarding the bypass, I think it's interesting in the sense that if you go back in time, probably 20, 30 years, it was very common for surgeons to be involved in terms of CABG as an acute revascularization strategy. But once primary PCI came along, that role, it has faded. And so, but the challenge, as you said, is that when you have patients with left main and very complicated, calcified disease, doing an extensive PCI with rotablation and things like that versus a straightforward CABG, CABG still has a role. And so we do involve our surgeons. The couple things we do, I think you can bridge with tirofiban in the short term if you want to stop their antiplatelet therapy and put them on tirofiban and then get them to surgery and then restart the dual antiplatelet therapy after surgery. Our surgeons have been, fine with that strategy. It requires waiting for 5 days, but if the patient has a very complex left main disease, and particularly if they have poor LV function, then we can usually get our surgeons to do that. We sometimes also do some type of viability study to give surgeons confidence that they're not dealing with a completely infarcted heart. And if they can see that there's ischemia or hibernation, then they get more interested in revascularizing that way also.
So thank you very much.
I have a slightly different theory, if I can talk for a minute or so. Yeah, if you look at the complete trial results, then there is no difference whether you do staging procedure before discharge or even up to 45 days. There has been no difference in the MACE. So if you translate the same results for CABG, for example, if you stent the culprit lesion and then wait for more than a month, nothing is going to happen, nothing is going to change. And if you look at the Leaders Free study or Onyx 1 study, even 1 month of DAPT is good enough and safe to stop DAPT after 1 month and then send them for surgery. So if we can translate the results of complete for CABG, we can actually give good result for a culprit lesion at the time of index angioplasty, primary angioplasty. That's my
I think a stable patient is fine. I think everybody will wait for 4 weeks. It's only the unstable patient or the patient who's giving you trouble post with a complex anatomy on the left, which is when the surgeons may have to intervene. So thank you very much. It was a great by Shireesh, and he will talk on management of thrombus, which I think is one of the biggest problems we face in the cath lab in a STEMI situation. Shireesh, as you know, is a senior consultant interventional cardiologist at Pune, and he's a course director for this meeting. Shireesh, please.
Good evening. About managing thrombus in cath lab. Intracoronary thrombus is a frequent enemy of a cardiologist in the cath lab, especially in ACS scenario. The thrombus visualization is challenging. 18% thrombus is observed on angiogram, but 86% thrombus is seen under angioscope. Thus, there is a high likelihood of a thrombus in ACS scenario. In the first 4 hours of STEMI, 88% of infarct-related arteries have thrombus. Impact of thrombus burden can be really deadly. There are various classifications of thrombus grading, but the one by Georgios Sianos is the one I like the most because it is simple, it is practical, and it is clinically relevant. Because at the end of the day, all of us are interested in knowing that whether the thrombus is a large thrombus or it's a small thrombus. Because small thrombus can be tackled easily, and a large thrombus is a different ballgame altogether. By definition, large thrombus is presence of thrombus with largest dimension more than 2 vessel diameters, and a small thrombus burden is either no thrombus or thrombus present with the largest dimension less than 2 vessels diameter. And does the presence of thrombus seen on a coronary angiogram affect the outcome after angioplasty? Definitely yes. The data set derived from 8 prospective randomized trials showed us that several adverse outcomes were higher in patients with thrombus, like death MI, significantly high. In-hospital abrupt closure, significantly high. And in-hospital triple MACE point, significantly high. Even the Mayo Clinic experience is not different. In presence of a large thrombus, there is a 3 times higher MACE, lower procedural success, higher distal embolization leading to slow or no flow, high mortality, persistent ST elevation, and a longer hospital stay. Compared to a large thrombus, a small thrombus, a large thrombus have high cardiovascular death, high cardiogenic shock, high heart failure rate, high stent thrombosis rate, and even a high stroke rate. Thus, a large thrombus may lead to poor myocardial blush grading. It can have a large infarct size. It may lead to poor TIMI flow, and it can lead to one of the most dreaded complications of a large thrombus, and that is no reflow or a slow flow. By definition, no reflow is TIMI flow grade less than 3 or a TIMI flow grade 3 with a TIMI MBG score of less than 2. It was first described in actually kidney in 1959, first time in dog hearts in 1972, and then finally in acute myocardial infarction in 1992. Frequency of no reflow varies with the method of assessment, ranging from 5% to 60% in different data. It's more common in degenerated vein grafts and following rotational atherectomy. It occurs more frequently in STEMI, but certainly seen in NSTEMI and stable angina patients as well. And no reflow is associated with very high in-hospital mortality, high infarction rate, high cardiogenic shock, and high incidence of heart failure. Not just on a short-term basis, but even on a long-term, say 5-year prognostic value of no flow, no reflow phenomena, it has got a lower survival rate, no reflow at the end of 5 years, and also has got a higher or a larger infarct size. No reflow phenomena doubles mortality risk in patients even up to 5 years. There are various mechanisms of this no reflow phenomena. The most important one being distal embolization from an epicardial vessel, coronary vessel, so that the thrombus is pushed down and it clogs the microvasculature. There is ischemia-related injury as well as reperfusion-related injury, which is mediated via multiple humoral as well as cellular mechanisms. And on top of that, there can be the individual susceptibility. There can be genetic variation, diabetic patients, acute hyperglycemia, they have higher chances of no reflow phenomena. And the treatment of a large thrombus can be frustrating many times. And hence the best way to treat no reflow is actually to prevent no reflow. And by doing aggressive and therapeutic anticoagulation, by aggressive antiplatelet therapy. But with that, I think we can only treat a small thrombus. What about large thrombus? For a large thrombus, we really need to have a mechanical strategy, a pharmacological strategy, and many times both the strategies together. Mechanical strategy can have a clot extraction using aspiration catheter so that you can aspirate the thrombus. One can use a stent to sort of push the thrombus behind the stent and preventing distal embolization. Or one can use different distal embolization protection devices, proximal as well as distal, so as to catch the thrombus. The commonest device that is used, mechanical device that is used for a large thrombus is thrombus aspiration. And in fact, when TAPS trial was published in 2008, it showed encouraging results with a lower MBG score, a greater ST segment resolution, and reduction in cardiac death at the end of 1 year. Hence, everybody started using aspiration catheter. But then 5 years later, TASTE trial was presented. It is a much larger trial, and unfortunately, it did not show any difference in 30-day mortality. Hence, the usage of aspiration catheter started going down. 2 years later, even a larger study was published called TOTAL trial. That also did not show any difference in primary ischemic outcomes. Not only that, but it also showed increase in stroke incidence. Thus, the recommendation for aspiration catheter, which started as class 2A in 2011 to 13, it became class 2B. That is only in selective cases, and in fact became class 3, which is like a contraindication, as no benefit in routine aspiration thrombectomy. And still we see that many of us are still using aspiration catheter, taking out this large serpentine thrombi from coronary arteries. And there are people who are still debating whether to aspirate or not to aspirate. What do? I certainly use aspiration catheter because I still believe that thrombus aspiration is useful in selected cases. And if aspiration catheter negotiates occlusion very easily, I just go for direct stenting, avoiding any predilatation. Plus, I use aspiration catheter many times for local drug delivery, the drug which is to be given either intralesional or beyond the lesion. There are other aspiration devices, something like an angiojet, which is a rheolytic thrombectomy system. It was tried in large thrombus, but it did not really show good results. There are multiple distal embolic filters that have been tried. Unfortunately, the meta-analysis of RCTs in primary angioplasty of various distal embolic protection devices showed no difference in mortality or any triple point MACE. It did not show any difference in ST segment resolution, and there was just a modest increase in MBG3 score. One can also use a stent to prevent no reflow. And believe me that a stent can be a very good solution for a small thrombus because it will trap the thrombus behind the stent and will prevent it from going down. One can also try direct stenting, and there are small RCTs for that. For the same reason, maybe for a large thrombus, but it did not really show many benefits, some numerically lower mortality and some ST segment resolution, but no significant benefit. There used to be a special stent called M-Guard, and that is a stent with a mesh net around it, which used to kind of keep the large thrombus behind the stent and not letting it go down at all. In fact, it was tried in a trial called Masters trial, and it did show superior rates of TIMI3 flow and ST segment resolution, but it was a bare metal stent. And I don't know, it was a good idea in principle, but somehow that stent appears to have disappeared. What about pharmacologic treatment of no reflow? And there are multiple medications which have been tried extensively, like adenosine, verapamil, diltiazem, nicardipine, epinephrine, nitroprusside, nicorandil, streptokinase, tenecteplase, abciximab, eptifibatide, tirofiban, and the list goes on and on. That drug can be actually delivered either proximally through guiding catheter, which is inexpensive and less selective, or it can be given intralesional with an expensive special catheter called Clearway catheter, or it can be given beyond the lesion through microcatheter, something like a simple aspiration catheter. All drugs have been tried in various trials. Here is a trial, Reopen AMI, which was carried out to test intracoronary adenosine and intracoronary nitroprusside, which did show complete ST segment resolution, especially with adenosine and less with nitroprusside. It also showed less angiographic MBO, especially again with adenosine and less with nitroprusside. But when it was checked with cardiac MR undertaken 24 to 96 hours after angioplasty, it did not really show any difference in infarct size or in presence of MBO or even myocardial salvage. So the end result was really not very, very encouraging. People have tried a larger dose of these dosages, especially adenosine, large dose with an infusion, but again, the results were not so encouraging. Verapamil diltiazem has also been tried in different smaller studies, modest benefit. Abciximab has also been tried either intracoronary or intravenous, and there is this meta-analysis of intracoronary versus intravenous abciximab. Again, there is not much of a difference in death or MI or all cardiac deaths. But when used in diabetic patient, it did show that there is a significant reduction in death or reinfarction compared to non-diabetics where there is really no difference. So it appears to be an encouraging Indian Jugaad balloon, which is actually kind of a poked balloon, a used balloon with perforation, multiple perforations, and that you can take it to the lesion and deliver your drug there. It's a simple idea, and I have been using it very frequently and many times with pleasing results. So after intralesional, one can actually give drug beyond the lesion as well using simple catheter. I use aspiration catheter many times with, again, good results. There can be another strategy which is called as deferred stenting. That is, instead of doing stenting at the time of index procedure, you send the patient back and call him back and do stenting at a later stage. And there are trials for that. Dynami 3 is the biggest trial for it, but unfortunately, the data really did not show any significant benefit. I think selective cases one can still do it, and I do believe that it can be useful in some cases. And lastly, imaging in primary angioplasty, either IVUS or OCT. With the help of that, one can clearly differentiate a thrombus from a lesion, and also one can pick up dissection very well when it is not really evident on coronary angiogram. With the help of that, one can precisely decide the lesion of the length of the lesion and the length of the syringe. But whether this will actually translate into any outcome benefit or not has to be seen. Thus, thrombus burden still remains Achilles heel of primary angioplasty. And I think the culprit for that is not really the epicardial large thrombus which is visible, but it is the clogged invisible microvasculature which is resistant to treatment. That is the culprit. To summarize, in patients undergoing primary angioplasty, there is still an unmet need for the prevention as well as treatment of no reflow. The available evidence does not support the use of intracoronary adjuvant therapy as a default strategy. Evidence on the treatment of no reflow remains limited to only small observational studies which are underpowered to prove efficacy. There is really no one-size-fits-all therapy for intracoronary thrombus. It warrants personalized therapy, mechanical and or pharmacological, and certainly needs multi-target strategies, targeting macro as well as especially microvasculature. Thanks.
Thank you, Shireesh, for an absolutely wonderful talk which covered everything related to thrombus and how you could manage it. Though we still have some problems with large thrombus, we are not very clear what is the best way and how to mix the strategies or what to use first or what to use second. I have just one question, and I think this is something and also a comment which we have been working on, which you suggested, and that is imaging in the scenario of STEMI. So we are now embarking on a large study, which is a randomized study on imaging in non-STEMI, because it's very difficult to image in a STEMI, the culprit, because of the flow-related issues with OCT. And what is interesting, it's going to be a CT-guided first round, followed by an OCT. And if the OCT shows a plaque erosion with a good size, that means the vessel flow is more than 2 millimeters square, then we give them medical treatment. 2B3A followed by aspirin Plavix or aspirin tecagrelol, and the other arm, which is either plaque erosion with lower, size less than 2, or if it's plaque rupture, you give them a stent and then follow them up for 1 month and 6 months. So this follow-up of the erosion 1 study, which was published in the Bernard journal by Gijang, which showed that clearly those patients can be medically treated. So I think if you mix all the pathologies, sometimes you'll get a different result on the study. And the same thing happens with thrombus. If you mix the small thrombus and the big thrombus, then the confusion happens in the outcomes, because the small thrombus does not require anything. It just requires a stent, while the big thrombus is what you need all these different strategies from. So your comment, Shireesh, and then Umesh, Ranga, and Rajesh.
Yeah, I think it still remains really an Achilles heel, and sometimes you get away with it and sometimes you don't. So we really don't know which patient to be treated with what, and we should try everything. That's what we try and end up doing. So,
Umesh?
I think one question that I had is that, since I've been coming to India, one of the things that I learned is that what we think of large thrombus in the United States and Europe is not large. I mean, in India, especially in small, in younger patients under 40, the thrombus burden is massive. And so I was curious as far as, is there any Indian experience with regards to, the benefit of thrombus aspiration and treatment in an Indian population, particularly young STEMI patients, because that disease process is something we don't see as much in the United States. So I was curious as to any comments on that.
So we just took the Tamil Nadu STEMI data and looked at the young STEMIs. When I mean young, it's really young. It's less than 40 years of age. And, the number of patients in the 2,400 was 18%, 1-8. These patients are mostly erosions. There are many smokers, 33% are smokers. And they behave pretty much well if you are picked up early and lysed, because they are predominantly thrombus in them. There's no plaque and there's no plaque rupture there. The second issue is that they have a better prognosis than older patients. We have not studied thrombus suction versus no thrombus suction in those group of patients, but that's an interesting thing we could do in the next phase. But they come earlier to the hospital, they get treated, they are in hospital 1 month, and 1 year mortality are better. It will be soon published. It's just come for revision. So I think it will be an interesting paper to see of a large group. It's almost, 20% of 2,400 patients. So it's a good group of patients to study. We also found that the young patients who are women do worse than men. And the young women also do worse than men because of the same thing which you discussed, Umesh, in your talk, that they think that they don't have an MI, they think they have a typical presentation, they sit at home, they come later, there's a lot of delay in treatment, and they get into trouble more often. So many of the young women as compared to the young men are diabetic. And I think diabetic removes the advantage of the hormones in women. And I think hypothyroidism is the second biggest risk in women, which we found. So these are very peculiar things. As far as treatment strategies, I think we don't have clear data on what is better and what is not. But I think thrombolysis, if you give it very quickly, works.
I think that would be something very useful to study because I think it's a different patient population as you've identified.
Ranga and Rajesh?
I think Shireesh has said it all. I mean, we've been speaking about thrombus and acute MI for a long time now. And we still look at, and we predominantly try to speak about the large thrombus, which these some of the aspiration catheters and thrombolysis local methods work. But once I think the microvasculature is just plugged, and that's where the big problem is. We might get a good-looking vessel after we did something, and we still have slow, no flow in the distal microvasculature. Those are the ones that after a couple of hours suddenly go into shock, and I don't think any other form of revascularization, even if it's bypass, I think it's basically delayed presentation and some sort of which really makes a difference. And as Ajit also said, looking at his Tamil Nadu data, and I think really I still don't think after many years, this is one particular area in acute myocardial infarction, thrombus management, we still don't have answers. I think we have to decide when we are on the table, we try various types of, and I think the patient is lucky and try and get away with the best possible result.
Rajesh?
Yeah, compliments for your talk. Very, very illustrative and very, informative and complete talk. I feel that whenever I do STEMIs, primary angioplasty, myocardial infarction, the two most dreadful, unpredictable features that loom on your head is more than dissection, the no reflow phenomenon or the slow flow phenomenon, the no reflow phenomenon. I'm totally flabbergasted when that happens, and it becomes so unpredictable that you don't know what the course of the patient is going to be. And so this is really an enigmatic problem. So usually, almost certainly, after thrombosect the whole thing, I inject nitroprusside even if the BP is low, I probably raise it up with NORAD and just infuse or inject nitroprusside so that the microchannels are open, and then, I proceed with the whole thing. So such is a paranoia which governs with this slow flow, no flow phenomenon. That's the only comment I'm making. The talk was really very complete, and these problems are going to arise, and we'll have lot many years to go till we find a solution. But so far it looks that this situation is enigmatic, and the talk was good. Thank you. That's the only comment I can make.
Thank you, everybody. And we'll go on to the last lecture by Dr. Ranganath Nayak, which is very, very current, and the use of dual antiplatelet therapy. There are a lot of trials in this area following PCI is getting shortened or lengthened. I think Ranga has a nice talk to deliver. So Ranga, as we all know, is very active at the Vikram Hospital, Bangalore. So Ranga, please go ahead. Can we have the slides of Ranga on?
Good afternoon, chairpersons and members of the STEMI. My thanks to you for having asked me to be part of this presentation. This evening, I'll be speaking to you on dual antiplatelet therapy, that is DAPT, in STEMI patients undergoing primary PCI. There are targets of the therapy on activated platelets. Now we know that the platelet is the principal part of the thrombotic cycle. When a person has a myocardial infarction, there's a plaque rupture and the platelets are activated. Now, there are a couple of drugs that act through different mechanisms. There's prasugrel, there's clopidogrel, which are the first generation drugs. There is ticagrelor, which is the second generation drugs. Then there are the GP2B3A inhibitors, and of course, our good old aspirin. All of us know this classical diagram which is there, which tells us how each of these drugs act. The antiplatelet drugs, if you look at, are basically, we know the COX inhibitors, the P2Y2 receptor blockers, the GP2B3A inhibitors, and the phosphodiesterase inhibitors. Aspirin is the COX2 inhibitor one. In the P2Y receptor blockers, we have the irreversible ones, that is ticlopidine, clopidogrel, and prasugrel, of which ticlopidine is hardly ever used now. The reversible one is ticagrelor and cangagrelor, of which ticagrelor is very actively available in our country. The second one is not. The GP2B3 inhibitors, the monoclonal antibody abciximab, and the synthetic molecules are the epipeptide and tyrofimab. And the phosphodiesterase inhibitors are dipyramidol and celestrozole. Of course, the ones that we mainly are going to be speaking on are aspirin, the P2Y2 receptor inhibitors, and a small part of the GP2B3A receptor inhibitors, because even their use in the present era has moved up from a class 1 indication down to a class 2B indication. So the currently recommended orally administered antiplatelet common use are aspirin, clopidogrel, prasugrel, and ticagrelor. Now, how did antiplatelet agents, when did we start using aspirin? Has been around for a long time. It was in 1988 in the Lancet publication, the ISIS-2 trial, where they showed that aspirin alone in STEMI had significant mortality benefit, and aspirin in combination with that fibrinolysis had even greater benefits. Since this trial, aspirin is a part of every management strategy in STEMI patients with or without PCI. This is a landmark article that was published in 1988, and we have been following that ever since. Clopidogrel is an irreversible P2Y2 receptor blocker. I'm not spoken about ticlopidine because it's not available anymore. It's recommended in STEMI patients irrespective of reperfusion strategy based on randomized clinical trials. Clopidogrel has never been evaluated against placebo or any large outcome studies in the setting of primary PCI. The use of clopidogrel STEMI has evolved from initial trials in ACS patients, basically acute coronary syndrome patients, undergoing PCI, and in patients treated with fibrinolysis before PCI. So, it is basically, and it's been applied to the present situation, and there are no definite trial which says that it is because of this that clopidogrel is useful. As far as prasugrel is a third generation irreversible P2Y2 inhibitor, which is very actively in use now, achieves faster and very potent inhibition. It can be actually chewed. In Trinitron TB38 trial, prasugrel as well, administered after angiography. One of the important things is that it has got a very high incidence of bleeding. But it's been in recent trials, but in spite of that, has been shown to be beneficial, especially in diabetics. It is contraindicated that we know in patients with prior stroke or TIA. It is not recommended in patients greater than 75 years or in patients with low body weight, less than 60 kgs, as there is no net clinical benefit in these subsets due to the increased incidence of bleeding in these patients. Now, ticagrelor is a drug that we most often use now. It's a P2Y2 receptor blocker which causes irreversible inhibition of P2Y2 receptor and does not require hepatic metabolism for its activity. So it's quite fast in its action when it's provided. I think it can be even given on the table during PCI. Provides more potent and consistent platelet inhibition over clopidogrel. And if you see when it's compared head-to-head with clopidogrel, ticagrelor has got a very good benefit, which is significant at the end of 12 months. The important thing are the recommendations now. If you look at the recommendations now, ESC or the ACC AHA recommendations for antiplatelet therapy, if you look at aspirin, it is recommended in the setting of PCI as a DAPT in all patients regardless of initial treatment strategy. It's a class 1 indication. Loading dose, of course, in Europe and America, there is a slight variation in the loading dose, and the maintenance dose is very little, but it's just a few milligrams. And I think in India, we most often use a maintenance, we use a loading dose of 325 mg, maintenance dose of 75 mg, and it's a class 1 indication. A P2Y2 inhibitor is recommended in addition to aspirin, maintained over 12 months in patients who undergo PCI, given at first medical contact, ESC, as early as possible at time of PCI, and it's again a class 1 indication. The options are, what are the various drugs that we can give? Prasugrel, 60 milligrams loading dose and 10 milligrams daily if no contraindication. Ticagrelor, 180 mg dose and then followed by 90 mg twice daily if no contraindication. Clopidogrel, 600 mg loading dose and 75 mg daily dose. ESC, only when ESC says that the European Society of only says when prasugrel are not available or are contraindicated, do we use clopidogrel in the present day era. As once upon a time, of course, clopidogrel was the only drug that was available. Now, once we have gone through the acute phase, how do we maintain antithrombotic strategy after ST elevation myocardial infarction is very important. When the patient leaves the hospital, what is it that we tell the patients? Most one is the definite is that antiplatelet therapy with low dose aspirin with 75 to 100 milligrams is definitely indicated. It's a class 1 indication. And it should be backed with ticagrelor or prasugrel, which is again a class 1 indication. And in case it is contraindicated or not available, then we can use clopidogrel. Also, if there's a high incidence of bleeding, then we can use a PPI, especially if you are using ticagrelor or prasugrel, and it's again a class 1 indication. In patients with an indication for oral anticoagulation, oral anticoagulants are indicated in addition to antiplatelet therapy. I'll come to few more recommendations specifically about this in the next few slides. I will continue on the maintenance thing. In patients who are at high risk of severe bleeding complications, discontinuation of P2Y2 inhibitors after 6 months should be considered. Yes, if there's a very high risk of bleeding, older patients who are very frail, and there's a high risk of bleeding, then but it would be a class 2A indication, that is discontinuing after 6 months. In STEMI patients with stent implantation and indication for oral anticoagulation, triple therapy should be considered for 1 to 6 months and to balance the estimated risk of recurrent coronary events or bleeding. Again, this is a class 2A indication. If there's no indication, it's best that we continue triple therapy, including DAPT for 12 months in patients who did not undergo should be considered unless there are contraindications as an excessive risk for bleeding. By this we mean if the patient has had an acute myocardial infarction, has been thrombolized, has been started on antiplatelet therapy, ideally we should continue DAPT for 12 months. But in case there's a high risk of bleeding and is not had a PCI, then we could consider stopping it earlier. In patients with LV thrombus, anticoagulation should be administered for up to 6 months, guided by repeated imaging. By that we mean by echocardiography. It's a class 2A indication with level of evidence being C. In high-risk patients who have tolerated DAPT without bleeding complications, treatment of DAPT with a form of ticagrelor 60 milligrams twice a day on top of aspirin longer than 2 months may be considered for up to 3 years to reduce the risk. Again, but this is a class 2B indication. For 12 months, we definitely require dual antiplatelet therapy. But after 12 months, if you want to still continue, if the patient is low risk, to reduce the recurrent events, there is a good indication that's a 2B, and the level of evidence is B. So unless you are absolutely required, after 12 months, you can switch over to a single antiplatelet therapy. In low bleeding risk patients who receive aspirin and clopidogrel, low dose rivaroxaban may be considered if there is an anticoagulation required, and it's a class 2B indication. The use of ticagrelor or prasugrel is not recommended as part of triple antithrombotic with aspirin and oral anticoagulation. So that's very important. If you're planning to do triple therapy, then it's best to use aspirin and clopidogrel. But that it's a class 3 is not recommended. It's a class 3 level of indication with the level of evidence being C. I think this is just the same slide, which are some things that I've spoken about. In a patient who has had a recent ACS, NSTMI, acute coronary syndrome, or STEMI, whose has a CABG, we should continue dual antiplatelet therapy for 12 months. If a person has only medical therapy after having any of these things, at least for 12 months, you can continue dual antiplatelet therapy, at least for 12 months with aspirin and clopidogrel. Lytic STEMI, again, at least for dual antiplatelet for 14 days and up for about 12 months with clopidogrel aspirin. And of course, with PCI, then of course, we have already given all the detailed indications that we would use dual antiplatelet therapy in form of aspirin plus ticagrelor or prasugrel. And unless it's contraindicated, then you would use clopidogrel. Now, special situations are patients taking or requiring oral anticoagulation, elderly, and switching agents. I think these are also 3 important points. If there are patients who's already on or requires anticoagulation, like a patient who's was an atrial fibrin, the addition of DAPT to oral anticoagulation definitely increases the risk of bleeding and complications 2 to 3-fold compared to oral anticoagulation alone. And if a patient is on oral anticoagulant, since fibrinolysis is a relative contraindication, if possible, these patients should be subjected to a primary PCI rather than fibrinolysis. Patients should receive additional parenteral anticoagulant regardless of the timing of the dose of oral anticoagulant. That's what we need is, if you're doing an oral, I think even if the patient has received oral anticoagulant, you would give the patient heparin during the course of the PCI. So patients on or requiring oral anticoagulation, in patients with a firm indication for oral anticoagulation, that's atrial fibrillation, charged VASC 2 or greater, so venous thromboembolism, a patient with a mechanical valve, oral anticoagulation is recommended in addition to then the recommendation is 1 by ESC. In patients with ACS and atrial fibrillation at low risk of bleeding, that's Hasbled score of less than 3, a triple therapy of Nayak and ASA and clopidogrel should be considered for a duration of 6 months, irrespective of the stent, followed by Nayak and aspirin or clopidogrel, continued for up to 12 months. So this is very, very standard therapy that's recommended by the European Society of Cardiology. In patients requiring oral anticoagulant, high risk of bleeding has blood greater than 3, triple therapy of Nayak and ASA and clopidogrel should be considered for a duration of 1 month, irrespective of stent, followed by Nayak and aspirin or clopidogrel after 1 month, if they are very high risk of bleeding, if the Hasbled score is greater than 3. One of the important things is that prasugrel or ticagrelor as a part of initial therapy is not, triple therapy is not recommended and is a class 3 indication. So don't use prasugrel or ticagrelor along with oral anticoagulation if you are planning if you're planning triple therapy. That's very, very important point to note. I mean, this is just once again about what I've spoken in the last 3 slides. What do we do with patients in patients with indication 4 and what do we do? I think I won't repeat myself. Elderly patients were at particular risk of bleeding and other complications of acute therapies because bleeding risk increases with age, renal function tend to decrease, and the prevalence of comorbidity is high. So if a patient is greater, do not consider prasugrel is a part of your DAPT, or in patients with low body weight, as it is not associated with net clinical pain in these subjects. In case prasugrel has to be used then you have to use it with a reduced dose of 5 milligrams is recommended in these type of patients. In case there's a contraindication for clopidogrel or some other thing, then you can use prasugrel at a lower dose. Now, there may be a variety of factors that a patient, you start him on ticagrelol or prasugrel or clopidogrel, and you have to switch, because of clinical setting, patient characters, concomitant costs, social issues, development of side effects, medical adherence, and patient or physician preference. So how do we do this switch over? This is 2017 International Express Consensus on Switching P to Y. So this is in the acute or early phase. I think the slide is nicely and self-explanatory. If you want to go from prasugrel to ticagrelol or ticagrelol to clopidogrel, how do you do it? Let's say you want to go from prasugrel to clopidogrel. Then you give 600 milligrams of clopidogrel, 600 mg of clopidogrel after the last dose of prasugrel and continue on maintenance dose. Other way around, if you want to give clopidogrel to prasugrel, you give prasugrel 60 milligrams after the last dose, irrespective of the timing and dosing of the clopidogrel, irrespective of timing. So, each of these things are very nicely shown in this particular slide. How do we shift between in the acute or early phase? And if it's very late or much later, after 1 month or 6 months, you want to shift because of various social issues, patients saying it's too expensive or saying I find it difficult, or have some of them have respiratory symptoms or bleeding issues. We can again shift between clopidogrel to ticagrelol to prasugrel to each other, and how to do it is very clearly and nicely illustrated in this slide. So take-home messages: use of DAPT is indispensable in the setting of primary PCI. Ticagrelol or prasugrel are preferable to clopidogrel unless there are contraindications. DAPT should be continued for appropriate length of time considering the ischemic and bleeding risk. In situations where oral anticoagulation is required in addition to DAPT, suitable modification should be made depending upon the bleeding risk. So thank you very much.
So thank you, Ranga, again for a very illustrative talk. So any comments from my co-panels, Shireesh, Rajesh, Umesh? Shireesh, we can't hear you. Please unmute yourself.
Sorry. It's about duration and intensity of DAPT. Now with the newer trials, the Twilight study and Tycho study and several other smaller studies, perhaps 12 months is not the right way to go. And perhaps we can go down on the duration as well as changing intensity from either prasugrel or ticagrelol to clopidogrel. I think the newer guidelines will come up with that, but what is the take on that? I mean, what do you think that should be the duration and intensity of DAPT now, post-primary angioplasty?
I think, Shireesh, still right now depends on what are the bleeding risks and what are the how you do that. But I think standardly right now you would still continue it for 12 months. Dual antiplatelet therapy, unless you think that there are particular patients has a very high risk of bleeding, like I said. So, sorry, I have not started my video. So, I think we would continue it for 12 months. And unless some contraindication is the patient has to have some surgery or there is some higher bleeding incidence, then I think I would continue DAPT with the standard, I think whatever the recommendations that are there. Unless, I think, do you have any other idea, any other recommendation, or do you think that you would do it something different?
Yeah, I think the recommendations will change. That's what I think. Yeah, the duration will come down.
Rajesh, any comments?
I think just one comment, two comments. Well, triple therapy, I think, is even in patients with a low bleeding risk. I mean, that still, if the bleeding does happen, it can be catastrophic. And so I would really feel nervous, even in a low bleeding risk patient, to put them on 6 months of triple therapy, even though that's what the guideline says. I think the data on the major bleed rates are, almost 30-40%. And so that's we really try to do 1 month and get them off of triple therapy as soon as possible. I just think that's not safe in the long run. I think the interesting thing in terms of, moving from DAPT, I think the future, eventually we're going to get to monotherapy. I think there's more and more evidence saying that we've always been worried about clopidogrel and ticagrelor and prasugrel with regards to bleeding, but aspirin also has a significant bleeding effect. And the combination of it, I think we're learning that maybe just putting people on one agent and taking off the aspirin, I have a feeling that we're heading in that direction.
Rajesh?
I think the new ESC guidelines last month have come up and they've said that for triple therapy, it should be given for 1 week. That is the latest guidelines that are saying.
Well, I think compliments for the presenter to Ranga for a beautiful, marvelous presentation. I feel that the DAPT duration is going to be shortened. 1 year probably is too long a period, because personally I see a lot of major bleeds, especially with the combination of Tika and aspirin. So I think there is an immense need for shortening of the therapy, and maybe multi-randomized trials will provide us the answers for that, because the bleeding with these potent antiplatelets, the newer ones, is pretty high, really. I mean, at least personally I feel.
And probably we don't really need it beyond 3 to 6 months. We don't need potent antiplatelet agents, really.
I think the risk of acute
potent antiplatelet agent is over by that time, by 3 months, 6 months.
I think 70% of acute thrombosis risk is 1 month. Yeah.
So I think there are some questions from the audience which we'll take quickly. If I'll try to answer a few of them, and if I don't, I will pass it on. So there's a question that pharmacoinvasive therapy, will it be as good as primary PCI if the lysis is beyond 2 hours? And that's an important question. And I think that Dr. Gersh answered that partially, that the more delay you have to ischemic time, then your lysis is unlikely to work, and their PCI is better. The cutoff time seems to be 3 hours, but we saw it in our trial up to 4 hours. So I think more the thrombus, maybe lysis works better in an Indian population. But I would say a cutoff internationally is at 3 hours, where primary PCI is better than lysis. Is bleeding risk only? Yes. Is bleeding risk the restraint for making pharmacoinvasive universal? I think that's the most important risk, and especially intracerebral bleed. Part of it has been reduced by the half dosing the tenecteplase in the elderly people and the radial approach, but we still have bleeding. We just published our meta-analysis in JAHA, which showed that mortality was the same with pharmacoinvasive and primary PCI, though the lysis followed by pharmacoinvasive had higher bleeding risk as compared to primary PCI. So definitely lysis has more bleeding, and you're combining 2 treatments. So obviously the risk of 2 treatments is more than 1 treatment. So I think that's one issue. Well, this is a very interesting question, and whether just plain balloon angioplasty of IRA is enough and you can refer the patient to surgery for complex. And I think we discussed it, not much data here on that, but I think that that's a very good option. We don't want to need a stent. We can get a good balloon and then maybe refer the patient in a month or whatever for surgery, so you don't have the stent-related issues in the future. But obviously the restenosis in that artery will be an issue in the future, which we need to worry about after that. One question is, COVID STEMI show more thrombus? And I think that's a talk which I will be talking tomorrow, but clearly that is yes, the answer. And it's basically because of vascular inflammation and immunothrombosis. and patients do have a very poor prognosis when combined with STEMI and a patient being sick with COVID. I think patients do very badly as compared to routine STEMI patients without COVID. Finally, the question, I think there are a couple of any comments on the age of thrombus. In fact, one of my colleagues is doing the study. For example, few minutes versus few days versus few months, is the thrombus different? And obviously the thrombus gets more organized. So your treatment options will change. In the first few minutes, if you get thrombus, your 2B3As work beautifully because most of it is white thrombus. As it gets more organized, it becomes more red. And there is where in a few days, if you see it, you can use warfarin and NOACs on a follow-up. And they do very well in plaque erosion. And we have OCT studies on about 27 patients of young patients with 24 hours post-thrombus. Finally, those who are organized thrombus, which typically on an OCT looks like a lotus stem appearance, none of these will work. So you need to treat them like a lesion and just stent them if they require it. Just treat it like a fibrosed lesion so they can be stented if they are ischemic. So I think each type of thrombus is different and imaging would help to differentiate these and you can make a decision after that. Can we use ticagrelor in patients thrombolized? There was a small study called the TREAT study, which showed that you can use ticagrelor, but there is no large randomized study with thrombolysis and ticagrelor. I suppose till that comes in because of the increased risk of ticagrelor by itself for intracranial bleed and thrombolysis for intracranial bleed, the combination could risk intracranial catastrophe. So I think it's not recommended today. So if there are any comments on these few questions, maybe my colleagues can add to it. Yeah.
No, I think we had a wonderful session.
Yeah, Shireesh, you can close the session if you...
Yeah, we really had a wonderful session and various aspects of primary angioplasty and STEMI we covered very well. So thanks to all the speakers, Dr. Umesh, Dr. Rajesh and Ranga. Thank you very much. And thank you all the delegates who have been listening patiently for the last 3 hours, 3.5 hours. So thank you. I think we wrap up for today.
Thank you very much.
Tomorrow at 6.
Thank you.
And meet again tomorrow.